link with glucokinase mutation. So persistent hyperglycemia with no chances of developing complication, it's likely to be monogenic. And I've often asked myself, which group of patients I need to refer for monogenic testing? 98% of time people are going to be type 2. It's that 2%. And is it relevant for me to do, such expensive thing of testing for the genes? Is there any need for it? The only point which I can reinforce to you, if you've got HNF1 alpha or 4 alpha, people are very sensitive to sulfonylureas. And occasionally in clinical practice, you can take people off insulin if they've been mislabeled as type 1. So that's the only relevance. Neonatal diabetes has been touched upon, so I'll not cover it. So there is something sorry, it only goes one way. I need to ask them to, oh goodness. Is it any way for me to go back?
Yes, sir. There's a button on that takes the slides reverse also.
Right, let's see.
In your slide changes.
Right. So there is no point in being uh, so IT naive from my point of view. Okay, that's fine. I've managed it. So for diagnostic criteria for monogenic diabetes, I'm sharing it with you. Oh God. Right. Remember, if there is strong family history, it's running in 3 generations, and I've got a running joke on it. Some people come to my clinic and say, diabetes runs in my family, doc. And I say to them that, okay, it because nobody runs in your family, diabetes runs in your family. So, anyways, I say it under a muted kind of breath. I don't say it loudly. So, these are the diagnostic criteria for monogenic. Okay, let's move on to the real game now. I've got around 32 minutes. This you need to pay attention from this point onwards. Happy with it? What do you think is the diagnosis here? Pre-diabetes. Everybody agrees? Say loud yes if you agree with it. Say no in a say everyone is wrong. Yep, it is pre-diabetes. So, and what do you think is the most appropriate management approach here? Like, what about metformins and GLP-1s? Is there any evidence for it? And how do we decide the cutoff for diabetes versus pre-diabetes? Why we call 7 as diabetes and under 7? Do the things change drastically at 7, which are not there on 6.9? We've given a fasting criteria of, let's say, 126 milligram or 7 millimole. What does change under 7 and what does change? No, I'm asking, if somebody is learned enough. There were some DM people in, some clinicians. Have you ever asked why 126 milligram or 7 is the cutoff? Why not 124? Which complication? The retinopathy was the first one. So the moment the glucose is high, retinopathy. And the retinal examination is excellent. That's the only place you can see the vasculature clearly. So, and what do we do with pre-diabetes? What's your choices? Physical activity, diet, and the third pillar is sleep. And if you go by the ADA diabetes recent standard practice criteria, they say we need to ask our patients to step, sweat, strengthen, right? So if you increase your step count by 500, your CVD risk reduces by 2 to 8%. If you start to um, do 5 to 6 minutes of brisk exercise, it it increases your life expectancy by around 4%, 4 years. So increase step, standing if you're sitting for a long time, Increased level of physical activity. The guidelines say around 150 minutes of moderate exercise over 5 days in a week spread over, or 75 minutes of high intensity things. How many of you are doing it? 150 per minute per week. Brilliant. You need to lead by example. You can't just say it. If you have to practice what you preach. Sleep. How many hours? Optimum. 6 to 8. Longer than that, not good. Owls do worse than larks. So early risers do better. And it's the quality of sleep which is important. So 4 pillars again: sleep, step, strength. And strength exercises are very important because muscles are the ones which have GLUT4 receptors. If there is increased muscle tone, I tell my patients it will eat out your glucose, so it lowers insulin resistance. If there is one single slide which is the most important one for you to spread awareness, it is this one. And if you think about it, pre-diabetes prevalence in um, UK at the moment is around 1 in 3 adult individuals. I don't know how much prevalent it is in other parts, but it's a huge challenge, huge burden for us. Let's move to the next real game now. We've covered diagnosis, classification very briefly. We talked about pre-diabetes. Next one. I'm just going through a story here. I'm not doing anything. 32, I'll call very young. When you reach age of 53, you think 30, I was a kid. Uh, on metformin, complaining of increased thirst and daytime somnolence, BMI 35.5, blood pressure 148 by 88 millimeter of mercury, and has background diabetes retinopathy. So if I ask you, and I'll show you these parameters, have this story in mind, because I'm going to ask you something on which you can reflect. HbA1c 55, which is 7.2%, trigs high, LDL cholesterol 3 millimole per liter. So my questions to you, and you've got a pen and pencil in front of you. I'll revise it. We've got half an hour tomorrow for clinical scenarios again. What will be your blood glucose target for this gentleman? What will be your target HbA1c? I'm not going to ask you loudly to answer it. I see a southpaw sitting on the front, which is, nice. Southpaw left-hander, supposed to be very intelligent. I'm an exception. Um, Glucose target, HbA1c target, blood pressure target, LDL cholesterol target, and body weight target. I'm not going to give any answer, and we'll go through this journey as we move on. Happy with it? So, second question. Are you okay with, have you written down your goals, Patrick? All good? So, what will be your preferred therapeutic option? Because we are clinicians. Anyone can mention about lifestyle, and most of my relatives when I visit India ask me about diabetes medication, and I ask them to walk, run, cut down their diet. They said, you're coming from UK, you need to give us good medication. You're writing metformin again and a statin, so you're wasting our time. Anyways, what will be your preferred therapeutic option for this gentleman to improve glycemic control, lower the blood pressure, lower LDL cholesterol and triglyceride? Have you written it up? I'm not asking for any answers at the moment. So when you make a decision in treating an individual, your goal of care should be around the person you are treating. You need to know about what they'll prefer, the comorbidities, how much can they afford. It's no point in having, n number of knowledge and having gone through every evidence base if your approach is not patient centric. And Management plan needs to be smart, in which, it has to be specific, measurable, achievable, realistic, and time limited. I've taken the slides from American Diabetes Association current practice guidelines published in Diabetes Care Jan 2025 last month. Thanks to Dr. Banshi and Dr. Amit, I had to revise them at a short notice. So glycemic goals, if I individualize them, ideally speaking, and this is again a personal opinion, if person is fit, well, I'll go for a normal control if I'm using medications which are not leading to hypoglycemia. And obviously cost of therapy comes in play here. Pre-meal 4.4 to 7.2, post-prandial peak less than 10, and if somebody can afford in type 2 and using CGM, target range over 70%. And if they are on hypoglycemia inducing medication, they should not be having hypoglycemia, right? So simple, nothing major. What about body weight? What is an ideal body weight? Do we think body mass index is a good measure of it? Yes or no? Body mass index, how many think is the best way to measure your visceral adiposity? So what is the alternative? Waist circumference? Are we doing it in clinical practice? How we do it? Why don't we rely on it? And some of the time when we label patients as normal body mass index, they may be sarcopenic. So if you're losing muscle mass, your body mass index may be low. If you've got good muscle mass, your BMI may be spuriously high also. So BMI between 25 to 30 is misleading. In fact, in Asian population, cutoff is 23.5, right? We carry more visceral adipose tissue. 3 to 7% from weight loss from the baseline will improve glycemic control. Greater than 10% body weight loss, usually at the beginning of the disease, will improve overall control and has disease modifying effect. I graduated in 95 and I remember rheumatoid arthritis management like a pyramid. You start with the basics, chloroquine and blah, 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 and end you go into more stronger immunotherapies and all. They were not even available then. The only thing which was available was methotrexate. I think the approach we use for diabetes needs to change, like rheumatoid arthritis was changed. You don't want complications to set in before you act. The reversal of pyramid for rheumatoid arthritis started in late 90s with availability of immunomodulators. Similarly, in type 2, we need to think totally out of box. You need to have a proactive approach and try your best not to let the complication set in. Moment they have got complication, probably you have lost a part of it, right? So I'm reinforcing the word disease modifying agents. I'll say if somebody is able to lose weight by whatever modality, that will lead to disease modification, and that's what our aim is. Okay, I didn't give you any answer because we'll discuss that part even tomorrow. And this was more for self-reflection. I'll cover this topic again in the next talk. So, sixth clinical scenario. Read it. 54, type 2 for 12 years. Second line, most of us are using at the moment is SGLT2 inhibitors. I normally don't use trade names, but in here I had to write a clinical scenario. So I had to write name of a medication, atorvastatin and losartan. Is complaining of generalized aches and pains. On examination, BMI is 30.5 kg per meter square. Happy with the clinical scenario? See her blood test results. There is deranged liver function, right? So my first clinical scenario was on pre-diabetes. Then I did early diabetes. In here, there is a lady with deranged liver function. So my question to you, which will be the most optimum therapy for management of a glycemic control, and that too in context of deranged liver function? Do you want to write it down? She's already on a metformin and a SGLT2 inhibitor. Glycemic control is still not optimized. Which medication you think will be the safer option with these liver function? Second question, which is clinically relevant here, what is the possibility of deranged liver function? Are you giving it a label of uh, what used to be NASH, now called MAFLD, metabolic dysfunction associated liver disease? Are statins safe in uh, if the LFT are deranged? Will you stop the statin? What will be your target LDL cholesterol? And I'll reinforce when I'm doing the CVD talk the importance of LDLs and all. How many will stop the statins here? Raise your hands with the liver function I had given. Okay. Anyone else? How many will continue with the statins? Good. We'll continue with it. Till the ALT and AST are less than 3 times the upper range of normal, you continue with it. When I'm seeing somebody with diabetes, I'm not looking at glucose, I'm looking at their CVD risk. Two-thirds of the patients with type 2 over age of 55 die of a cardiovascular event. So CVD risk reduction is extremely important in diabetes. So how many will go for therapy wise? What will be your third line here after metformin and SGLT2? If everything is available for you with deranged liver function, what is the safest choice here? Pardon? 1%. I think if you are loud enough, it's. I don't know the evidence for it. I know it's used in here. I have no idea about the evidence. Low dose pioglitazone is an option. I'll show it to you. Remember, we are talking about evidence-based medicine, evidence which is, you know, looked at in a proper way. And my request to you here, whenever you are analyzing a paper, keep the pharmaceutical bias away. Please don't be taught by the billion-dollar industry. I'm son of a doctor, and in 1995, my dad, when I mentioned a trade name, said, "Do not use trade name, the pharmaceutical, use pharmaceutical names rather than the trade names. Trade names change. Your development of concepts develops on your ability to understand the mechanism of a medication. You will be sold multiple medications, but you need to learn how to appraise the evidence. I don't know about the Salazar you're mentioning. You need to look at what kind of RCTs they showed benefit, and go through that paper in a deep detail, right? This is something which, if I had time, I would have gone with, I would have asked the organizers to keep um, review of critical review of the evidence as a total different kind of topic. So anyways, coming back to the clinical scenario, we need to assess the diabetes complications, assess CVD risk for heart failure just based on history, risk of hypoglycemia also in history. Then we do the examination to uncover any retinopathy, neuropathy. And then we do the biochemical investigation to look for derangement of liver and renal function, assess glycemic control. So, you know, we are clinicians. We need to do things in a systematic manner and make it a habit to do it. Make it part of our existence to go by history, examination, and then investigation to support it. So anyone with diabetes, if you've taken history, done the examination, and made a plan, you'll uncover what is the priority you need to focus on. So this is a diagnostic algorithm for prevention of cirrhosis in patients with metabolic dysfunction associated liver disease. One easy thing you can do in clinical practice is do the Fib4 scoring. If you know the ALT and AST and know the platelet count, in this slide I've mentioned how to calculate Fib4 score. If it is higher than 1.3 or equivalent, you can think about doing a fibroscan. Fibroscan will give you an idea about the liver stiffness, and then you can make a formulate a plan. As a physician, if patients have fibrosis, cirrhosis, you need to refer to the specialist rather than trying to do it on your own, everything, right? Now, metabolic dysfunction associated steatotic liver disease, the treatment algorithm. There are three aspects to it. Weight loss remains the key. How you achieve it is based on the resources available. Diabetes pharmacotherapy. Most of the guidelines will mention about if it's F0 and F1, which is no or mild fibrosis, going for metformin, SGLT2, and GLP if patients can afford it. MASH specific pharmacotherapy, which as an endocrinologist excites me, is for F2 and F3 group. Unfortunately, this is still not available in EU at the moment or UK. But the FDA Americans have approved this medication, which acts on thyroid hormone receptor, which is beta selective, increases free fatty acid oxidation. I've mentioned the name in here. I've not used it. And again, this needs to be done or carried out under experts supervision. So moving on to the clinical scenarios, I've got 12 more minutes. We started our journey with a pre-diabetes. We covered somebody with new diagnosis of diabetes. We mentioned about diabetes and liver disease. Now, people age, unfortunately. It's an irreversible process. I wish I could stay, 16 at heart, which I am, but when I look at mirror, it's totally different. 78-year-old with established cardiovascular disease comes to you in the clinic on multiple polypharmacy. Some of the time it gets difficult about to know which of these cocktails is doing benefit and which is doing harm. Has lost considerable amount of weight since diabetes was diagnosed. BMI is only 23.5, still carrying some adipose tissue around. So I'll share the results with you here. Element of anemia and renal impairment, HbA1c of 58. Liver function is normal, but has diabetic nephropathy. So my question to you now, right? And you need to write it down because I'm not giving any answers at the moment. I'll spend time over the coffee or over a cup of coffee or tomorrow's clinical scenario session. How do you manage diabetes in people who are getting old and frail? What should be your HbA1c target in this individual? How many will be happy with, let's say, 7% or 8%? Brilliant. Safety of medication and renal impairment. He was on metformin, he was on SGLT2 inhibitors, he was on statin therapy, he was on ACE inhibitor. How many will stop metformin? I'll remind you, EGFR was 37 or 38, if you've forgotten. How many will stop metformin? You do not stop metformin till EGFR is under 30. And the evidence for, non-safety of metformin is more historical based on fenformin data, not metformin data. So a gradual decline in EGFR, I don't stop metformin, even at EGFR of 25. Steep decline, steep organ failure, acute organ failure, you stop it. Lactic acidosis with metformin was not seen in UKPDS. So yes, the guidelines will say EGFR of under 30, stop it. But if it's a gradual decline, you can think about continuing it, right? Not under 20, but definitely 25 to 30 group. I don't stop it. SGLT2, should we stop it? I think pharma driven, lots of lectures. We know if EGFR is over 20 odd, we need to continue with it. Even in non-diabetes patients, we drive benefit. It's not the glycemic benefit, it's with progression of diabetic nephropathy. So when I started, teaching about SGLT2s, I remember saying, do not use it if EGFR, do not initiate if EGFR was under 60. Things have changed. So the non-glycemic benefit stay for SGLT2s till as long as the EGFR is over 20 mil per minute per 1.73 meters square, right? And impact of polypharmacy. We published a paper back in 2020. That was the only positive thing I did during the COVID time, apart from catching it and ending up with uh, severe lung disease. Anyways, your glycemic control or glycemic goals do change with life. When you're younger, you're fitter, you're healthy, and definition of health is different. When you've got poorly controlled diabetes, you are adding 10 years to your biological life, vascular aging, right? So stringent controls, if somebody is fit enough, frail elderly, be a bit more relaxed. In addition, older adults with limited time frame, let them be happy without letting them go into hyperglycemic, hyper osmolar syndrome. Let them be happy. If you think mortality is an issue, don't chase the numbers, treat the patient. Very complex slide in here. Uh, I'm not going to go into the details here because it's part of ESD and ADA criteria. You would have seen it often. Heart failure, nephropathy, SGLT2s have emerged as almost first line. I'm not counting metformin here. GLP-1s, if available, or incretin therapy, if patients can afford it, especially in the context of CVD, makes a difference. You need to consider insulin if you think patients are insulinopenic, right? So I'm not going to talk about this slide. It's available online and you can go through it. It's ADA recommendation and EST endorsed. Lastly, you need to think about holistic patient-centric approach. I'll again reinforce there is no point in acquiring knowledge if you can't apply it to the patient around. Treatment needs to be individualized. So, my take home message to you, I just wanted to go through some clinical scenarios. Think about diabetes. I'm talking more on type 2 rather than type 1 terms here. It's a lifelong disease, it's not static. When you start the journey and when you end it, it's different. So you need, as clinician, to adapt to it. Always focus on the comorbidities and make sure through your history taking, through your examination, through your investigation, you are focusing on these and then prioritize what is important to you. Therapy needs to be individualized and you need to have a proactive management early in life because you may need to use disease modifying medication or lifestyle interventions. And as we age in life, we need to simplify the regime. 80-year-old, my mom is 80 at the moment. She can't remember which medication she's taken, which she's not. And many of the time she repeats the same medication. Make sure the elderly, the frail you see in the clinic, medication regime is something which they can understand. Prioritize on the ones which are safe. In as a physician, the only thing I've learned is the lesser medication I've used, better I am. And try to apply the self principle to the patient. Will you like this to be done to your own self? It's easy to give a cocktail of medication and then not knowing what the concussion does within the system. But if you keep it simple, results are much easier to interpret. So I've got less than 5 minutes and I've got 5 MCQs. Let me see how many of you were awake. The organizers are not here. If people get all right, they should have been given a hamper of chocolates or something. But chocolates would have increased your blood glucose. I don't prefer it. Question one. Let's see how many were paying attention. Out of the three pillars, apart from diet and um, increased level of physical activity, what is the third pillar for pre-diabetes? Sleep, 6 to 8 hours, 6 to 8 hours. So get away from your screens, the social media, and then try to sleep for 6 to 8 hours if you can. Second question, that was an easy one. So a 30-year-old comes into your clinic. He's been diagnosed to have diabetes around 18 months ago. BMI is 38 kg per meter, quite healthy. Yeah. And these are the results. My question to you is, what will be your preferred therapeutic option here? Brilliant. If affordable, I think the only one available in India at the moment is Ribelsis. The results are um, modest at the moment for Ribelsis. It's less effective than the injectable. I think the dual incretins and others are far more potency-wise impressive. Third question. So all fine so far, right? Everybody's getting correct answers. Mid 50s guy on a metformin and a DPP4, ACE inhibitor and statin. And this is my to go to thing. If you are on a metformin, a statin, ACE or ARP, you have done your job. The rest of the things are bonus. BMI of 30.1, deranged liver function, raised LDL, FIB4 score of 1.3. This is slightly more complex, right? So my question to you, how many will go for A? Pardon? E, is it? B, start SGLT2. Happy or is there any consensus here? I'll show you the scenario again. I can't go back. So FIB score was 1.3, borderline. I would have optimized the therapy using SGLT2, right? Or pioglitazone at a low dose. I don't use more than 15 milligram, right? Fourth question. I've got only two left and I've got 2 minutes, right? 70-year-old on a whole cocktail of medication, ACE, DPP4, metformin, aspirin, uh, aldosterone antagonist, non-steroidal, and a statin, TIA and osteopenia. These are the blood test results. So this patient has diabetic nephropathy and which of the following is the most appropriate in her case considering development of chronic kidney disease? Are you anyone else? Stop Finrinan? Yeah, you can continue with it as long as the EGFR is 25 to my knowledge. Stop linagliptin? No. Stop metformin? No, because you need EGFR to be over 30 as we discussed. Initiate SGLT2. As long as the EGFR is more than 20, it will have nephropathy protection effect. Last MCQ, 42 seconds. 62, not long to go for my retirement age, right? So on metformin, SGLT2, bempedoic acid, complaining of increased thirst, nocturia, osmotic symptoms, BMI of 26.5, HbA1c of 88, right? Happy with the scenario? I want a loud answer so that I know you are awake. Well done. Is insulin
something a little uncommon for me, but yes, this is for me. Okay. Is the clicker. Okay. Okay. As I said before, it's for me a pleasure. Yesterday I've been flying for 14 hours from my office to be here in this city, and I would like to thank Banshi Sabu for inviting me and the organizing committee. As I said, I'm the president of Primary Care, an NPO, the only one NPO that is working non-profit organization in primary care and diabetes in Europe. And I'm a medical doctor. I'm doing clinical work in Barcelona city in a primary care facility. Okay. And I'm in a group practice where a total of 38 GPs, we are providing service to, in a big center we are visiting 50,000 citizens. We have a prevalence of diabetes, and my colleagues are referring me those complex diabetic patients to be considered to be attended in my clinic. Okay, and I'm also visiting other kind of patients, just like normal patients in primary care. So the idea of this session is trying to move forward. These are my disclosures. Is trying to talk about a concept that is the idea of chronic complications of diabetes, micro and macrovascular complications. But at the moment we have in the field of diabetes, a lot of things coming. We have a lot of technology. We have a lot of challenges and barriers. And sometimes, although we are talking about, I said, mitochondria and things very specific and very scientific, we are not paying attention to simple things. And the dialogue, diabetes education, if what we are learning in these sessions, we are adopting in our clinical work, in our clinical field. Because adopting is very complex, is not easy, okay? So the idea, and now we have a big tsunami of things. We have better access to data, and that data allow us to know what is our performance, how we are doing things ourselves, and try to learn from our gaps, from our areas of improvement. So I have to talk today about two aspects, as micro and macrovascular complications. I try to do a journey. Probably in my perspective, a lot of these things you already know. I try to provide some glimpse, some new concepts or ideas, okay? But let's start. I think that, of course, you know, this classification is a classical one, and it talks about micro and macrovascular complications, and is related what is the vessel that is damaged due to the diabetes disease and the other comorbidities that are living together or at the same time of that person that is with diabetes disease. So, but it's important probably to keep in mind some, initial thoughts. We know that between 50 to 60% of persons living with diabetes have some cardiovascular disease. We know that around 40 to 44%, but that depends of how the disease is detected in your country, is also diagnosed of chronic kidney disease. Also, we know about that diabetic foot and non-traumatic amputations, the main cause is diabetes. We also know that around 16% of those over 65 years old with diabetes die from a stroke. And we know that in women is more prevalent than in men, okay? And also we know that all those individuals that have diabetes over 40 years of age, they also present retinopathy. And we know that diabetes as a disease is impacting in many places that are providing a lot of disabling to the persons that we are visiting in our clinic. So it's very important to put the focus on that. One study I've been participating, and I think it's a good moment to share with you, is what a person with diabetes is looking for or waiting in the first contact when the person is informed that he has diabetes. And has been performed a project, is called Time to Do More, that is published in Diabetes Research and Clinical Practice, where it is trying to compare what were the expectations of persons diagnosed and what were the expectations of the healthcare professionals, and trying to match. And I don't know what could be, what do you think, but the match, it was not really good. The expectations of patients that were diagnosed, it were about complications. And the expectations of the healthcare professionals, it were trying to insist on diet, physical activity, and maybe starting medications. But those things that worry most persons with living with diabetes are complications. So I think that is, and that it was a study not in Spain, it was done in many countries, Spain, Brazil, Japan, UK, States. So I think it was consistent everywhere. So sometimes healthcare professionals, we need to try to hear more what are those things that are worrying our persons in front of us, to understand how we can start a better dialogue and probably to involve the person in that process. Of course, I mean, probably the pathogenic explanation why hyperglycemia is provoking or is probably responsible for this damage at macrovascular places is well known. This has been studied, and there are many pathways that could explain that. Okay, and also there are different biomarkers that also are those ones that could explain in that pathways at the end that we are incrementing an oxidative stress and a pro-inflammatory status, and that could be the cause of providing damage on vessels at macrovascular level. So, but at the same time, we know that, and we know that in 1993, DDCT for the first time project why it has sense to treat diabetes. And I have been fortunate myself because I've been in the room when UKPDS was presented in 1998 in my city. And that also provoked a lot of surprise because before that date, we just trying to treat hyperglycemia, but we don't really have strong information about what were the consequences of being tight or not tight in metabolic control. And besides that, this is in DCCT in type 1 and in type 2, a lot of trials after just targeting blood glucose and also blood pressure and lipids were projecting the benefits of being probably following some targets. Also, the STENO2 trial also emerged the relevance that probably not all the persons we have in front of us are equal in terms of risk, because it was demonstrated that those individuals with type 2, also with microalbuminuria, were at a higher risk, and they have very important benefits in mortality if we target all the different risk factors in those patients. So I think it's important to keep that in mind, because that will open us the window and the reason why we have to try to be intensive or to share with our dialogue with patients why it's important we establish some targets, not just in metabolic control, also in other things, as a kind of a contract. And it's something I normally do. When my colleagues in my center, they are visiting type 2 diabetic patients and type 1. But sometimes they feel that they cannot move forward. They feel frustrated because patients are not really reaching the target, or because the patients are not adherent. Keep in mind, 40% of patients in Spain, 40%, 40, are not taking their medications for diabetes. So non-adherence is an issue. I don't know in your countries, but in my country is an issue. What we are doing for that? So talking about complications, it's opening a window about the reason why we have to treat this disease. Because patients are not having, majority of them, any complaint. They feel because the sugar, as they say, are not damaging them at that moment, is silent. The problem is when the sugar has a voice, because then probably the damage is not probably to be back. So let's start talking about retinopathy. I mean, we know about retinopathy. We know because retinopathy has been a very indexed complication in terms of diabetes. Before has been talking about the thresholds of diagnostics in type 2 and type 1 diabetes in general, and we know that that coming from epidemiological studies in retinopathy. Okay, so I think that retinopathy is well identified. We know it's more prevalent in type 1 than in type 2, but that is due persons living with type 1 are living for many years and have more time to evolve with complications. So here we have so the pathogeny of the disease. We know that there are different mechanisms, but I would like to pay the attention that also there are other risk factors. It's not just the glucose, it's also the high blood pressure, it's also that some hormones stress that can induce more risk to evolve with retinopathy. That's why when we have a person living with diabetes and is become pregnant, that we have to pay special attention. That it means that probably we have to do more screening or more checks, okay? Because that is a risk, a situation that increases the risk of retinopathy. Also, is also known that those ones already having some microvascular complications as chronic kidney disease or have kidney damage as albuminuria probably has a higher risk of having retinopathy. So, of course, kidney, and also there are some ethnicities that have more risk of evolving with retinopathy. How we are detecting retinopathy? And this is now having more changes, and probably I don't know how you are doing that, but we have moving from direct ophthalmoscopy in indirect, or probably referring the patient to an ophthalmologist. But now, and I don't know if here is also available, we start working with a portable retinographs. So a system like a mobile that you put in the eye, you pick a photo that goes to the cloud, and then you receive a report, and the system tells you when you have to do next check. Okay? Because there's artificial intelligence also matching with the data of that person, telling you what is the risk of that patient to evolve retinopathy. And probably the idea of doing every 2 years, every 5 years is not anymore. Maybe depending on that kind of new algorithms is suggesting you to do it, I mean, lasting more time, or probably stratifying the risk of that person's that you're doing retinopathy. This is now a lot of emerging medtech innovation in that field. It's important also to understand, I don't know if you're doing reading of photographies of retina, but in my country, GPs are doing that in clinic. We are doing this technique in a facility, not in the eye clinic. We are doing in our primary care centers. And we are doing the reading also in primary care centers, doing shared care with the ophthalmologist. But of course, that depends how you are organizing healthcare. That is not in every place. I mean, the important is to provide the service. Another way is probably if we are sustainable how we are doing. But I mean, there are many ways to do it. But we are doing like this in my country. Another piece of another tool that has been very helpful lately is the optical coherence tomography. That one is trying to project data about the macula and the damage that in the macula is produced also in diabetes. So this is mainly used in eyes clinic, not in the primary care setting. So here we have a classification, and of course when we are detecting retinopathy, in some we are sharing that with the ophthalmologist, and that it goes immediately to the eye clinic. So we are just doing the screening. Okay, when that is recommended. And in type 1, you see here projected, in type 2, a diagnosis, and then every 1-2 years. But as I said, artificial intelligence is going to introduce new changes on that domain as well. And pregnancy is inviting us to do it more frequent. There are also this evidence about the benefit of being tight of metabolic control of blood pressure, that it also brings benefits in terms of reducing retinopathy. So it's not just glucose control. So glucose control, blood pressure, stop smoking, photocoagulation if needed, and maybe other techniques that are more in the eyes clinic domain. The kidneys. Okay, the kidney has been a kind of reborn in the past years. Why? Because we have new compounds that now, for the first time, from probably not first time, it's 9 years, when empagliflozin and the EMPA-REC trial was published and was presented in Stockholm ESD in 2015, is when we start having a new wisdom of we have compounds that change, probably could change the evolution of the diabetes, okay? And that has been a big change, and you know, because it has been projected before with the strategies in therapy. The etiopathogenesis of diabetes you probably study in the medical school in the physiology, okay? Hyperfiltration, nephron stress, blah, blah, blah. You know that. I mean, it's not question of that. We have to go to the key points. But something that is not really well known, and probably for you could be a big surprise, is, of course, in just to keep simple, and that it will be maybe sticking in our minds, in the minds of the colleagues that probably you are advising, because majority of you here, you are endos or you are diabetologists, but you have a lot of GPs around you that you coach. And I think they need to understand that when you are assessing the kidney, it's not just the creatinine, is also the different estimation formulas you have. I mean, at least to use one. The ideal one could be CK-EPI, is the most, use it, or recommended, but also the damage, the albuminuria. Okay, why? Because that invites to also to put on the agenda of your colleagues the kidney. And it's not just to check the function, it's the function and the damage. And also invites the clinicians, your colleagues, and maybe yourselves as well, to stratify what's the risk. Because it's not the same that you have a person with microalbuminuria or the level of microalbuminuria, or you're observing a EGFR decline. This is very important because the risk of that person is much higher to another. So that makes that your attitude must be completely different in that individual compared to the other. So that is a sense. And because we have also tools to use on that persons. So it's normal, it's physiologic. We know that in the with the aging, we're having a loss of the function, okay? But another story is the damage, and is the loss of proteins of albuminuria in the urine. And that's projecting damage in the nephron. And this is highly correlated with mortality. So we need, as we know that hypertrophy of left ventricular is also in the heart, is associated with complications, we know that albuminuria is a biomarker we need to keep in mind. That's why it's important to keep sense what we're doing always, because sometimes we don't provide the value to the actions we are doing. We are testing the albuminuria because that helps us to stratify the risk, and that helps to understand if we have to do something else to that patient, and that helps to us to explain the patient that is in a high risk situation and our efforts must be different to another person. So don't neglect the importance of all these things you are doing to incorporate in your communication and in your dialogue. So here we have in the next two slides, this and the next one, which ones are the non-modifiable risk factors and which ones are the modifiable ones. Of course, age is not modifiable, diabetes duration, genetic factors, ethnicity, etc. But those modifiable ones are very important to keep in mind in terms to know how we are going to work in terms to improve and to be better in terms of nephropathy. So dyslipidemia, hypertension, I mean, also we know that sedentarism is highly correlated, obesity, metabolic syndrome, I mean, also recurrent chronic infections are something that could be a cause of worsening in diabetes nephropathy. So what's saying KDIGO about that? KDIGO and the International Society of Nephrology has been working in terms to help all the scientific community to provide a simple way to operate, to understand chronic kidney disease, diabetic kidney disease. And this is a document we work together, my society, Primary Care Diabetes Europe, together with KDIGO and the International Society of Nephrology. That is a downloadable document that is trying to help any clinician in a very easy manner how to identify individuals, how to, what are the best aspects to keep in mind in terms to test that or to assess that kidney, okay, in terms of the function and the damage, as I said you before, and also how you have to diagnose chronic kidney disease. It's also mentioned that we know that now we are probably have a gap and we have an important area of improvement, mainly in terms of albuminuria. You know that the EGFR is a calculation. You can calculate. There are some labs that are projecting the value automatically, but there are others that you have to calculate by your own. But albuminuria is a parameter that is more complex to reach in many places. Also in Europe, in many countries, they are not allow clinicians in primary care to call for albuminuria. Probably it seems very strange, but that's real life. So how we are going to do a good assessment of a person if we don't have all the parameters that are going to help us for that? So this is an area of importance to keep in mind. Probably also to revisit in your countries, in your settings, if you know that probably is an area of improvement. Of course, why we need to test these two parameters? Because as also is projecting that, and this is very well known because it's a KDIGO color map that is helping the clinician to understand in what position you are, and then if you have to treat, and also maybe if you have to consult and you have to refer. Okay, so that is very important in terms to put the person in that place and then react according to that. Of course, in terms of chronic kidney damage, I think we visit now what has been the last version published last December, January of the standards of care of the ADA. And that ones are trying to project that when you have a person in that situation, that are the different scheme of therapeutics that are recommending. Besides metformin, and consider that metformin is contraindicated when you have eGFR below 30. You have also a strong advice to start using SGLT2 inhibitors, okay, without no specification of which one you have to use it. You have to use that mechanism. And also you have to also other tools to consider. Of course, on top of that, you also have other things to be considered if you are not reaching your targets. But of course, again, you need, and then if you see in that blue lines boxes, you see what is the diabetes pathway or roadmap that is recommending you to follow in case that you would like. So starting with SGLT2, and maybe if you are not under control, maybe consider the added value that GLP-1 receptor agonists also project and demonstrate that could be beneficial. So here is important that it's just not these compounds, that other things, and this is just a summary of what we already seen in that 2025 standards of care of the ADA. And of course, we have not to neglect that when you have a person with diabetes kidney disease, It's also other comorbidities before I mentioned retinopathy, okay? But it's also other things we have to keep in mind, because diabetes, when it's damaging the vascular tree, is not just targeting one place, it's targeting many. Let's move now to diabetes neuropathy, sorry. And diabetes neuropathy also is important. That is one of the microvascular complications. And here also is related to this reduced blood supply, and is producing ischemia in that vessels, and that invites for this damage and neuronal damage, and of course diabetic neuropathy. Here we have a classification in terms of neuropathy. Probably that one is more studied and have more impact, is that is related to amputations. Amputations are related to peripheral neuropathy, and of course when you are living together with vasculopathy, peripheral artery disease, okay? But I think that here we have a summary of what we understand as a diabetes neuropathy, the autonomic neuropathy, the peripheral neuropathy, and I would like to be more focused on that one. Okay, but probably it's important, and sometimes it's more rare, but sometimes we have patients that are affected with gastrointestinal neuropathy, and sometimes it's very difficult to manage that ones in terms of chronic diarrhea, other complaints, and this is a very complex situation, and it requires a specific advice and management. Okay. But I think that, and of course, also this, when you are suspecting in patients that could have like cardiac autonomic neuropathy, that you need to be familiar with the different cardiograms. You can observe the different patterns. And that is also a high-risk individual because can be affected at cardiological level of this neuropathy. Of course, something that is really not really well studied and known is about, and I see now, is sexual dysfunction. And it's something that could be bothering a lot of your patients in your clinic. Okay, many of them, and probably they feel like shy to share that in the dialogue because they feel guilty, because they feel, I mean, in terms of their masculinity, etc. But sometimes if you open the discussion that a person living with that chronic disease and taking some specific medications, considering is a person living with diabetes and together with high blood pressure, they have a higher risk of having problems in that field, in the sexual dysfunction. Probably if you open that in a conversation, open conversation, that provide you surprises, and sometimes maybe more engagement of that person, what you are telling, not in that domain, in the other things, because you are empathizing with something they are feeling really as something they would like to share, but for them it's difficult to do it. They feel like in a kind of a bottleneck. So in terms of peripheral neuropathy, it's important to keep in mind that this could be affect up to the 50% of persons living with type 2 diabetes. I think is normally is symmetric and polyneuropathy, but I think it's important that to detect that one and to do it well. But sometimes, I don't know you, but I see that we are doing things in automatical manner. I see in clinic, okay, I'm observing. Sometimes, and you know that is clinical inertia in management of diabetes. We know that we have persons with values of A1C over the target, and we are not reacting for years. Okay, we did a study in my country because we have access to all the database of diabetic persons, and we know that starting with a second medication, it takes more than 4 years with values of A1C over the target. So it's clear is a clinical inertia. So when we are calling for a specific parameter, we need to do it because we would like to do something else. If not, please. Doing things automatically is horrible. In that case, I see sometimes how the food is explored, monofilament, and I see that maybe you are detecting a person with a high risk of diabetic food, and that you are not activating any educational action, any when you are detecting a person that is not reacting to monofilament due to the you're suspecting diabetic neuropathy, what you need to do is to start doing some kind of advice in terms of education, kind of shoes, take care with your socks, how you are cleaning, how you're cutting your nails, etc., etc. Because if not, you can have the problem, and when you have the problem, then it's very difficult to change. So I think it's important how we do in the screening. We need to learn the techniques, and sometimes the techniques are not really well performed. I don't know if you are doing that technique or it's done from a personal in your center, but if you have the opportunity, please go and see how they are exploring diabetic food, because sometimes the technique they are doing to do it are also forcing some answers, and then what you are observing probably is not real of what is happening in because you are inducing answers, how you are exploring or how you are trying to use the techniques to do the assessment of diabetes neuropathy. Here we have a classification, but it's very important one thing. We are not going to have amputation if we don't have two factors. One will be three factors. We need for sure neuropathy. Second, vascular problems, okay? And then could be also some kind of different problem in the how we are on the articular problem in the joint, okay? Because, and then it means that when you are detecting neuropathy and you are loss of sensation with the monofilament is a orange light that needs to invite you what's next. And that is, I think it's very important just to avoid that. And of course, if that person has some level of vascular disease, peripheral vascular disease. So what I'm saying that, because when you are detecting some level of what is projected here, low, moderate, or high, then that invites you to examination frequency. The examination frequency is just to revisit what's going on, to understand if the patient is following your advice, because then when something is happening, sometimes it's too late. Okay, and as I said at the beginning, the most frequent cause of amputation, non-traumatic amputation, is diabetes. Okay, so it's important to manage the disease, and something that provokes a lot of discomfort is the painful neuropathy. So we know that some compounds as pregabalin, gabapentin, duloxetine, and amitriptyline also in the past, but have a lot of side effects, could be medications to be considered to support and to help the patient suffering of painful neuropathy. Let's move now to the last part of my session, that will be the macrovascular one. I think it's here we have the ischemic heart disease, heart failure, and peripheral artery disease. Okay, and this is a definition, arteriosclerotic cardiovascular disease is defined of all of this list of things that is listed here. But it's important to know that that is the leading cause of mortality in diabetes. So, of course, arteriosclerotic cardiovascular disease is a really key aspect to keep in mind where you are managing persons living with diabetes. So we know that approximately 1 of 3, so 33% of people with type 2 have any cardiovascular disease. And we know that 20 to 40% of people have heart failure. Heart failure is, again, another disease, another thing that have like a reactivation, okay? And also a lot of enthusiasm in other specialties, okay? Like cardiologists, and that is very good because that allows us to detect more people, and that it means to provide solutions to that people that need solutions, okay, in terms of compounds. But we know that at least in my perspective, heart failure, it was an area, a clinical problem that it was not really well diagnosed, not really well detected, okay? Of course, now we have better access to techniques. We have also the peptides. We also have echocardiography, the sonogram. We also have in some centers echoscopy, what they say echoscopy. They are doing sonogram, more simple one in the primary care setting to do an initial assessment. But of course, heart failure is an area that sometimes people were living with. It was not really well diagnosed, and that, of course, we were not offering a good approach. In terms of cardiovascular disease, I think it's very important, and this is an infogram coming from the last ADA standards of care, that we need to keep in mind that there's a basic thing that is lifestyle modification and diabetes education. Of course, lifestyle modification is very complex. I mean, I don't know how many of you, when you have to start to take a medication for 7 days, you finish the medication. Imagine you have to change the things you are eating, your physical activity, etc., etc. So we need to empathize with that person's in front of us, and of course, not the same recipe works for everybody. When we have a person over 75 years old, and we tell them you need to do physical activity, what is the person knowing is not going to happen anything? I have the answer. It's not going to happen anything. You need to teach in the clinic what must be the exercise you recommend to that person, and probably to provide an example. Very simple, but you need to help them to twist the coin. Because if not, if you are just providing and doing very like the claiming, that is not going to change anything. It's the traditional approach. So lifestyle modification, and we need skills to provide advice, to provide good education that impacts, okay? Because we know that probably what we are doing is not working, okay? So we need to stress how we are delivering our education, okay? Ourselves. Also, I incorporate that in that exercise. Of course, when we have discovered, we have the person aligned. We need the person is willing what I have to do next. Look, something I did it for the first time, my colleagues, and this is a personal experience. I did, okay, before starting doing anything, I ask, why are you in my clinic? What is the reason you are here today? And they don't know. The doctor sent me here. They don't know what is the reason to be there in the clinic. So it's important. They need to be the owners. And then that it means they have the commitment, and that will be the critical factor for them to react and to be committed in the advice you are introducing them. Second thing I do, please, for the next day, 1 week or 2 weeks, please make photos with your mobile of the dishes you are doing. Make a photo and bring it to me, okay? And also take this paper and write what you're eating, not the quantity, what you're eating, like qualitative, okay? And bring it to me. That is the first test to know what is the patient commitment. Patient coming to the clinic, not bringing photos and not bringing the paper, I say, okay, I don't have information. What do you want from me to do next? I need that one. I provide a second chance, a second opportunity. But if the patient is not bringing me information, I said, I'm sorry, but I cannot help you. Okay? Because, this is an example. You need to adapt. But the thing you would like here is to reach the commitment of that person to be the critical part of the change. Okay? Of course, if we would like to improve glycemic control, blood pressure, lipid profile, all the cardiovascular agents, this is a teamwork. And the person that is driving the car or driving the bike is the person living with the problem, not ours. We just are coaching, okay? Okay, and this is aspects that, of course, are covered with the former slide. Aspects important to keep in mind in terms of screening that things, okay, is when have any reason to screen coronary artery disease, routine screening is not recommended. It's not recommended. if no is any symptom. When you have a symptom, when you have a breathless, then you suspect maybe heart failure. Then is another thing. But screening without symptoms is not recommended. What's going on with heart failure? That's a different story. When you have some comorbidities, or maybe when you have some symptoms, then you have to react in a more organized manner. A peripheral artery disease. Every time the person came to their foot clinic or to the foot examination, you do the monofilament, you test, and you test the pulses. And you also ask about the potential of having any claudication walking. Okay, that is allow you to know something is going on. All your radars, your examination, all the communication. So that is very important in terms to start activating the screening. Of course, the screening to do something else. Okay, here are some more slides about how to address, and then in terms of management. And I think it's important to keep in mind that what are the solutions. That is an example, is again from the ADA 2025, so this last version, and how we have to understand the hypertension management on those persons, okay, and how we have to start. And I think, of course, it's clear when you have the values over 150, 90, you can start with 2 compounds. When you are, and then of course, and that are other parameters that are going to invite you to understand what must be the first component, the first medication you have to start using in that specific situation, because if the person has or not has albuminuria, etc., etc. Okay, this is following the algorithm. If you are not reaching the goals, you need to intensify the therapy. You don't have to delay. If you are doing that, you have to do it in a proactive manner. But that's your job, our task as a healthcare professional. The task of the patient is to provide you the blood pressure results. Your action must be to visit that results, comment that results with him or with her, and then react according to the results. Okay, and here, of course, is in terms of heart failure, we have to consider the use of the medications that probably you completely know. And of course, here is how we need to incorporate that new compounds that we know that are now, of course, in all the different guidelines and the case of the heart failure. Of course, peripheral artery disease, and that is the last thing I'm going to talk about. I think it's awesome when a person came to your clinic, you need to start paying attention. I'm just going to explain you about a personal experience. My grandfather was type 2, my grandmother type 2, my father is type 2 diabetic, and my father is also 23 years hypertension, is well controlled for compounds, etc. And my father goes to a pediatric clinic, okay? And went to the pediatric clinic, and after 4 or 5 days, my father said, I have a pain in the feet, and I have it's a little cold, and I go and see the feet. It was completely blue, has an ischemia. So, I mean, it's important, and my father was visited by a podologist 3 days before. What's going on? I mean, it's very important when you are, and that was happening at least for 10 days. When you are in clinic and the person is let you know, I have something, like in that case, we are talking about peripheral artery disease. I'm walking in the street. I force because I have problems in my legs and I don't know what's going on. That forced me to stop, and then I start walking again. And then when you examine the foot and you examine the leg and the pulses, all of these have to invite you to see something is wrong. I need to activate the alarm, and then I have to think about hypotheses and probably being more proactive on what's going on. And we have a test. We have the ankle brachial index, okay? We are doing the ankle brachial index, but then again, we understand the results. We are reacting according to the results. Is results interpretation inertia? please, if we are in that step that we already do a test, as we are doing kidney assessment, as we are doing A1C, and you are doing annual brachial index, react according to the results. And then if the person is smoking and have high blood pressure, have other conditions, try to be tied with these factors, okay? So, and this is my last slide. And this slide try to see, okay, maybe probably the idea of macrovascular complications need to be more open, okay? Because there are other things we know they are living, other comorbidities. We know about the paper, the role of the liver. We know for many years. We know about, and now we know new compounds are going to come and to do a blossom of the liver in terms of the management of diabetes, as we have at the metabolic syndrome in late 90s when we have the glitazones. We have, or the postprandial wave. Okay, do you remember? And it was a lot of fashion about taking postprandial, okay? Because we have acarbose, we have repaglinide, we have other compounds. But don't feel like this is something that allows us to invite and to revisit the pathophysiology of the disease. And sometimes all of these complications are interconnected. And it's not just niche in one specific disease as diabetes, have other important comorbidities, and we have to make this important diagnosis that allow us to see what are the aspects we have to keep in mind for a good management of that persons. So thank you very much.
Hi. So this is for changing? Yeah. Okay. Great. Yeah. Good evening, everyone. I'm Dr. Om J. Lakhani, and thank you for a wonderful talk. And I think I have to follow this up with now from diagnosis and classifications, we are moving to therapeutics. So I thought this was supposed to be a school, and school is supposed to be interactive. So I think those at the back, this is going to be completely interactive. Okay, you'll be asked questions. If you need a coffee, there's one right outside. I suggest you grab one, right? Because I'm going to ask you questions. So again, if you're at the back, I suggest you come in the front so that we can be more interactive. Okay, so we are going to talk about insulin therapy. Again, like a school. Well, like an ideal school, we'll be having a lot of, a couple of cases. Most of these cases are sort of real life cases. So again, try to find a mic near you because like I said, we'll be asking questions. So, we'll hope you'll answer that. Okay. So let's begin. Many of you are in the WhatsApp group. So we have put a link there. You can just check out that link on the WhatsApp group. You can use this here also. Yeah, you can just use this QR code. You will be able to access some additional notes, right? There'll be some research articles. Very importantly, there'll be certain mini applications. Remember, insulin is a lot of it is mathematics, so you'll be able to access those data as well. So you can try to use this. The same thing is there on the WhatsApp group also. Okay, so and I'm very sure that at the end of the presentation also you'll be able to access this more or less in perpetuity. So you'll be I hope it'll be useful to you in the upcoming times in your practice as well. Right. So this is what it will look like, right? And you can when you access this, right now. Before we begin, yeah. Okay. So this is the outline of the talk. So this is what we are going to discuss in the next 43 minutes. When to initiate insulin, what are the types of insulin and different insulin regimes, how to titrate the insulin, how to inject the insulin, and storage and transportation. A lot of it is basic. I'm sure you're all used insulin in your life. But what we're going to do is we're going to talk about the nuances of that and mainly how to apply that knowledge in your clinical practice. Now, I'm a very firm believer of a very unique way of learning, and that's there on our, the platform also, the link of which I've shared, and that's called the Vedantic model of learning, where knowledge actually transcends into three stages. Okay, so one is this, right, where you learn imbibe the knowledge. And then there is what is known as manan, where you reflect on the things you learned, right? So that's a very important aspect of knowledge, right? So reflection is very important. So I think if you're making notes, if you're taking notes, or if you're taking pictures, go home and reflect on what you learned, right? So that you'll learn better. And the third part is what is known as nidhi asan, basically using what you learned in your practice, right? So on Monday, when you go back to your own clinics, a few things what you learned in the entire session, right? I hope you start applying that in your practice. And that is what solidifies medical knowledge most, right? So if you follow these three steps. So let's begin with the first situation, when to initiate insulin, right? So what are the situations where patients always need insulin, okay? Or more or less always need insulin? Type 1 diabetes, I'm sure you'll agree, right? A type 1 diabetics will always need insulin. A patient presenting with diabetic ketoacidosis. Now, when a patient presents with diabetic ketoacidosis, we don't know whether it's type 1, it's a ketosis prone type 2, we don't know, right? So, well, more or less, patient would need insulin. Diabetes in pregnancy, well, there is some role of metformin, I don't want to go to controversy of that, right? But more or less, you'll need insulin. Pancreatic diabetes, type 3C diabetes, right, would need insulin. Perioperative patients, right, patients undergoing surgery, right, more or less will need insulin. Generally in hospital patients, we start them on insulin. And patient with often other organ involvement, maybe end-stage renal disease or a end-stage liver disease, again will need insulin. Right? So these are the patients where insulin is more or less, I'm sure you'd all agree that the patient needs insulin, right? Most of these situations. The problem really lies in that type 2 diabetic patients, when do you start insulin? That's the part which is most contentious, and that's the part which is most applicable to our clinical practice also, because you're going to see these patients day in, day out in your practice. So what type 2 diabetes patients need insulin, and that is what we're going to discuss. So let's start with a case. Okay, so this is a 30-year-old. A lot of these cases I'm going to show are real patients. Okay, real patients who actually came in with. So real patients have real problems. Okay, we have, as doctors, we face real situations, right? So this is a 30-year-old male patient, lives in the US, came to India on a family vacation. He then started having, so he was there for a longish vacation, staycation kind of situation. He started having unintentional weight loss, polyuria, polydipsia. And then, his aunt was a pediatrician. This is an adult male, right? But aunt was a pediatrician. She immediately recognized that, okay, these are signs of diabetes, right? So, she asked for some checkup. His father already has type 2 diabetes, which was diagnosed when he was 47. And this guy has a BMI of 27. Okay. Now, this is what, and this is where they immediately, they came this is again, 2022 case, right? So these are the reports, right? So like I said, the aunt is a pediatrician, and aunt said, okay, now this is, boy, you have diabetes, right? And she gets this test done. And you can see the random sugar, the fasting sugar is 400. The postprandials are also very high. HbA1c is 13. Creat is 1. Other things, LDL 196, very high. Triglycerides are very high. SGPT is high. TSH is more or less normal. Interestingly, and this is where we looked at, you have these things, but the patient does not have ketosis or ketoacidosis. Patient walked into the clinic with very high sugars, but no ketosis. Okay. So, yeah. So, okay, let's pause here, right? Let's take this case here. Okay. I'm sure you'd say that, it's very obvious that the patient, you're going to land up with patient requiring insulin for sure. But when this patient comes to you, what do you think this is, right? Again, I already gave up that this is type 2, but let's say, you don't know anything about this case. The patient just walks into you, right? The aunt is a pediatrician and the patient comes to you. Type 1, type 2, how many of you think it's possibly type 1 diabetes? Yeah. Okay. Why not? Why is this type 2 and not type 1? Okay. But how age? Because now I'll tell you, my youngest type 2 diabetic is 11, and my oldest type 1 diabetics is 84, right? Newly diagnosed. So age is just a number, right? Okay. Anything else? Okay. BMI is 27, but I'm sure you all have seen obese type 1s as well, right? Of course, not, if they, yeah, yeah. Family history of type 2, yes. Okay.
Metabolic syndrome like with the triglyceride and LDL also high.
Okay. Yeah. Correct. Okay. That's point in favor. Anything else? Absence of ketosis, right? So I think, one red flag which immediately kind of puts you in that. Well, patient has a blood sugar of 400, yet no ketosis. Okay. Again, that's one point very strongly against the type 1, right? It's anybody's game here, right? It could be anything, right? But let's kind of argue these things out, right? So this is one point, and that's the point where this is specifically I highlighted, right? That the patient did not have ketosis. Now, when you have a person with absolute insulin deficiency, very likely, especially a type 1, right? Very likely with a blood sugar of 400 with polyuria, he will develop ketosis, right? It's very unusual that he does not. Not only does he, I'm not saying ketoacidosis, doesn't even have ketosis. Okay, so which is again one flag. So in these cases, what we do is we do something called a mixed meal stimulation test. Well, we could very well have done a random C-peptide also, but let's say we did a mixed meal stimulation test. In a mixed meal stimulation test, what we do is we ask the patient to come in the morning fasting. We take a fasting sample. We take a C-peptide along with that, and then we give a standardized liquid meal, right? Internationally, it's Sustekal. In India, we use Ensure powder, which is similar composition. And after 90 minutes, we take a sample again, and we check the C-peptide again. Okay, so this is what we did in this patient. Okay, and we also looked at the antibodies, so GAD65, IA2, and all that. So these are the results. Okay, so the patient's fasting sugar on the mixed meal was 275. C-peptide was 2.95. Well, I should mention the unit, so it's nanogram per ml. Random sugar, the post-meal sugar is 413, and again the C-peptide is right. Now, as a rule of thumb, okay, again we have some calculators for the mixed meal stimulation also, but as a rule of thumb, what I'll generally suggest to you is that when you see these values less than 1, okay, 1 nanogram per ml, you are probably dealing with type 1, right, with our absolute insulin deficiency, right? So if this patient's fasting blood sugar is 275 and his C-peptide was 0.6, I'm thinking type 1, right? So, even with a negative GAD antibody, right? So don't always rely on the antibodies, right? So that's be careful, right? What if it was the other way around? Let's say patient's insulin production is fine, right? It's not deficient, but his GAD antibody is positive. How do you classify that? Anybody? So a patient comes to you, same patient, right? Only thing is what we changed in the reports is that the C-peptide now is fine, like what we have. The only change is, let's say his GAD is positive. What is that classified? He's 30-year-old. Correct. Late onset rather, right? Yeah. So that's the artist formerly known as LADA, right? Which is now basically LADA is a slowly progressing type 1 diabetes. That's what it is, right? So it's a type 1 only, but it progresses so slowly that the patient doesn't become insulin deficient for a while, right? So if the GAD antibody then here was positive, then that's what is actually the definition of LADA, right? That's what the LADA actually is. The only thing is, maybe the patient didn't need insulin for 6 months and all that. These are technicalities. But the point is you have autoimmunity positive with preserved beta cell. That's LADA, okay? So it's a type 1 which is very slow. That's what it is, okay? So moving on. So here we have this, on the platform, you can see we have these kind of little mini applications, right? So you can try it out. Does my patient need insulin? Okay. In fact, we made some time back, we had an app called Centurion Insulin app. We actually put this into the system. The idea was we often see in clinical practice, a lot of patients who need insulin, who come to us, but they have not been started on insulin by the physicians. It's very sad, right? So that's the whole point. So we have this kind of application. You can try it out. You can put in the key in the data, right? So in this particular situation, obviously this case it's very obvious that the patient needs insulin, but that's the thing, right? So what we finally diagnosed based on this is that this patient has type 2 diabetes, with severe hyperglycemia. That is what the patient has. But then comes the million dollar question. Does he need insulin? Okay. Now, how many of you are going to prescribe insulin to him? Yeah. Okay. How many are not going to prescribe insulin to him? Why not, sir? Yes. Okay. Fair argument. Okay. Another fair argument. Okay. Any other arguments of not giving insulin? So that's why these cases are important, right? These cases are very fact that these cases are important because this is what the exact argument will be. Okay. Any arguments? Any other arguments against giving insulin? Okay. Any arguments for giving insulin? Can we have some mics? हाँ, yeah. Mic है तो option एक पे. Hand mics. Yeah, please. Okay, excellent point, right? So patient has glucotoxicity, and when you give insulin to these patients, you can actually preserve the beta cell, right? That's very, very valid. In fact, excellent argument. I think there's no, beating this. Any other arguments, right? What are the signs of glucotoxicity in this patient? Right, correct, right? So the patient has osmotic symptoms, okay? Patient has osmotic symptoms. Osmotic symptoms being polyuria, polydipsia, weight loss, unintentional weight loss, which this patient had, visual blurring, okay? Patient is going to be miserable for sure. If you are this patient, you are miserable, okay, with a big M, okay. The very reason why, and I agree that patient may not agree, right? That those are arguments which are always valid. Human arguments are always there. But if you talk about from a physiological perspective, and I think he nailed it, two very essential points here. One is the fact that patient has osmotic symptoms. So when you have a patient presenting with osmotic symptoms, it's always better to start the patient on insulin. Having said that, the physiological argument is that, like he very rightly said, now there are studies for this also, and there are smaller studies. A lot of these studies actually come from, these may not be always true for Caucasians, but for Asian patients, and there are very, studies done from China and India, that when you give insulin to this patient, it gives rest to the beta cell, leading to preservation of beta cell, right? Remember, and this is a very important fundamental process, right? In fact, I was reading some very interesting similar discussion on Twitter by one of my endocrinologist friend. The thing about diabetes management, and think about, since we are in this diabetes management conference, always think long term, never think short term, right? Think about how the patient is going to be, right, 10 years from now, right? We just had a talk on microvascular complications, right? Remember, this patient is not going to concough or die, right? We'll not allow that to happen. But what we are thinking about for a 30-year-old with a type 2 diabetes is what's going to happen to him when he's 40? What's going to happen to him when it's 50, right? What will happen to him? What will happen to his beta cells? What will happen to his cardiovascular risk, right? What will happen to other complications which he can develop, right? So think in a long-term perspective, right? And think in a long-term perspective, do everything at this point of time which can help him on a long-term basis. And the third, again, a human argument, right, here would be the one treatment which is going to give him the most symptomatic relief for sure is going to be insulin. He'll feel better, right? And I think there's no better argument than that, right? Patients come to you for feeling better. Patients don't want to feel worse, right? So the essential argument here would be, again, these points, right? So patient has these symptoms. Again, if you see guidelines also, right? HbA1c guidelines, most guidelines say, including the ADA guideline, that HbA1c more than 10% and random sugars more than 300, you should consider insulin, right? That is there in every guideline. Now, of course, ADA guidelines is more moving towards GLP. But I have this one theory, right? I'll always remember. See, a lot of times, guidelines are fine. Guidelines are okay, right? But you're dealing with real life practice, right? And I always have this theory. When your patient comes to you in a catabolic state, right? Always give therapies which will heal that catabolic state. Patient comes to you in an anabolic state, right? Weight gain and everything. Give therapies which will reduce that, right? So a patient comes to you with unintentional weight loss. Give him drugs which will help him regain the weight, right? Which will restore that balance, right? Like insulin, maybe even SU. But the problem with SU is that SU cannot be very well titrated, right? There'll be, there are challenges. And once the glucotoxicity breaks, the patients with the same dose of SU will start developing severe hypoglycemias. That's the problem with SUs, right? Uh, if this patient is given and this is again what I've seen in practice, and this is disastrous, if this patient is given an SGLT2 or maybe even a GLP, a patient would actually get worse, right? Now, patient is already having polyuria. Yes, the sugars will come down, right? But you're worsening that, right? And the patient then feels more miserable, right? And we don't want our patients to be miserable, right? That's the point, right? So a lot of times in clinical practice, and we often now with SGLT2 in India being very freely available and being very, cost effective and cheap and available in every corner of the country, a lot of the times we have started getting patients who are having good sugar control, but they are not happy, right? They want to meet you because I am taking this medicine, but I feel worse. Okay, so that is what happens sometimes when you give SGLT to the wrong person. Patient actually feels worse. But if this patient was 35 kg per meter square with complaining to you about gaining weight, acanthosis nigricans, I have gained edema, dyspnea on walking, SGLT2 would be the first choice I'll give, right? Because then that drug will help him feel better. So that's always the argument, right? Again, there's a school of thought that precision medicine is ultimately what we want, right? But the precision medicine is always dynamic in nature, right? So when the patient first comes to you, a different set of medicines will work. Maybe if in the future this patient may require some other forms of treatment, right? So this is what the ADA guideline says. I'm not going to do details of that, right? You all know the guidelines in and out of it, right? So we'll then move to case number 2. Any questions? Like I said, it's interactive. Yes, sir. I, yeah, I don't disagree with you, right? Like I said, real life practice is often, different, right? But again, in a very ideal setup, let's say in an ideal situation, let me ask you this: in an ideal situation, right, where you have all the therapies available, patient is ready to, like this patient, his aunt was just standing right in it. Whatever you say, he'll take. I'll ensure that, right? Whatever therapy in an ideal situation, cost is not a barrier, other things are not a barrier, and patient's education is not a barrier. What therapy would you give then? Exactly, right? So that's the whole argument, right? So that's the point, right? So what you said is, I don't disagree, right? I agree with you, right? There will be, a lot of the times, but then the argument really comes that if no other things are there, what's an ideal treatment, right? That's the point. We don't know. No, we don't know about exhaustion, right? That's a debatable area. Uh, there used to be a school of thought. Maybe the older generation beta cell had some exhaustion things. Maybe giving this patient beta cell, stimulatory therapy, will it exhaust the beta cell? We don't know that. It will not preserve the beta cell for sure, that we know, right? So because you're still using the same system, right? What are the long-term implications of that? We don't know. But in a short-term implication, like I said, what happens is when you give an SU to this patient, you have to keep a very tight control, close watch of the patient, because insulin you can always titrate. So let's say we start with 10 units, you can increase to 12, reduce the dose, increase the dose, right? It's a very titrable form of treatment, right? Whereas the problem with SU is that when it's given, right? You have started the patient on 1 milligram, 2 milligram of glimepiride, whatever. Even asking the patient to, go and take 1 milligram if he's already taking 3 milligrams is going to be difficult, because what patient will do is, no, I'm having this medicine, I have a stock of this, I'll finish this and I'll take 1 milligram, right? So a lot of the times, and we have seen patients like this, right? Once the glucotoxicity breaks, they start developing severe hypoglycemia. Again, patient getting worse, right? So that's, again, these are things we have to be really, careful about, right? Okay. Let's move on to the second case. Okay. So 58-year-old male patient, known case of type 2 diabetes since last 8 years, recent worsening of diabetes post-COVID. As you can see, it's an old case. Currently on a glimepiride, 6 milligram, voglibose, metformin, DPP-4 inhibitors, mainly coming to you with neuropathic symptoms. So these are the clinical presentation of this patient. Let's look at the lab results. Okay, so this is the lab result. Fasting blood sugar is 164, post meal is 293, HbA1c is 9.1, creatinine is this, LDL is fine, triglyceride is fine, SGPT is little high, TSH is 7.4, and vitamin D is 13. So these are the reports of this patient, right? So let me just rephrase this. This is the patient, okay? Now this patient is on 1, 2, 3, 4 oral antidiabetic drugs, right? 4 oral antidiabetic drugs, and his HbA1c is 9.1. Okay, fine. What would be the treatment you'll offer to this patient?
Basal
Okay,
insulin.
basal bolus. So, okay, how many for insulin? Okay, a lot of us are for insulin. How about, again, devil's argument, right? How about SGLT2 try nothing kari? Let's put SGLT2. Fair argument. Okay, what about GLP? Patient can afford, right? I heard a lot. Patient comes and says, I heard about this new drug, life changing, game changing. Can I take that? Yeah. Let's say I remove the DPP4 and put the patient on a GLP. Fair argument? Fair. The problem is the clinical evidence and a lot of studies have shown that when you have a patient on 3 or more non-insulin based therapies, giving a fourth doesn't have an incremental benefit in terms of HbA1c reduction. At best, it does an HbA1c reduction of 0.2 to 0.4%. And this patient's HbA1c is 9.1, way away from target, right? Adding a fourth drug or a fifth drug or a sixth drug is not going to bring him to the target of 7. That's the essential argument. The only thing which is safe, universally acceptable, easily titrable, where there's no limit to the upper limit of the dose you can give is insulin, right? And perhaps then, right, insulin is the best option in this patient. But you can also see glimepiride of 6 milligram, very often seen in clinical practice, right? At some point, right, remember SU stop working, right? They simply stop working, right? So I've often seen this in practice, again, a common mistake, which often happens. You keep increasing the dose of glimepirides like it is insulin, right? And you end up having no benefit for the patient, right? You know, patient starts with 1 milligram, then it's 2 milligram, 3 milligram, and you will, I mean, you know, you think I'm crazy, but I've seen a patient on 16 milligram of glimepiride, right? That's the highest I've seen, 16 milligram of glimepiride, right? I really don't understand, right? When it's not working, why keep increasing the doses of the medicine? So I think that's a little wrong. At this point of time, the only therapy that is really going to be helpful for this patient is going to be insulin, right? Nothing else is really going to give an incremental benefit. And that's why the guidelines, in all their wisdom, both the RSSDI, ESI, and all the other guidelines typically say that insulin therapy should be considered for all patients failing to achieve glycemic targets with 3 or more oral antidiabetics. Consider initiating insulin with patients with severe hyperglycemia or unstable state. This is what the guidelines say. Again, you can put it in the little app that we have, right? Try putting the data and you will get a similar result. Okay. Moving on to the case 3. So let's see this patient. Okay. 50-year-old patient has acoustic schwannoma, planned for neurosurgery after 1 week, diagnosed to have type 2 diabetes just a month back. Okay. I'll move a little quick. I'll try to finish as much as possible. The rest of the materials is there, including the presentation is there on the the link that I gave you, right? So feel free. I think it's better that we learn a few concepts in detail rather than try to kind of cover everything, right? So my target is not going to be finishing the course. My target is going to be giving you as much pearls as possible. Okay. So there's a patient with a random sugar of 400, glimepiride, SGLT2, metformin, everything he has. Now he was uncomfortable with these medicines, so he stopped these medicines on his own, right? Except for glimepiride, which is just that he's not comfortable with SGLT2, so he stopped it on his own, right? These are the reports of this patient. So blood sugars, again, real life patient, 288, 356, HbA1c of 9, right? Okay. So again, I think this is very similar to what we discussed, and I already told you that catabolic state, another very important perioperative thing, right? Guidelines are very clear. Perioperative state, you should stop SGLT2 inhibitors, right? It's a separate discussion and all, so I'm not going to go into that. But the point here is that perioperative situation, be careful. Do not take euglycemic ketoacidosis for granted, right? there are a lot of physicians who come and say, oh, I have not seen euglycemic ketoacidosis. I tell them you have missed out. You have missed out. It's very common. I mean, it's not very common, but it's common. The problem is it often goes under the radar. Why? Because blood sugars are normal, right? So you often miss that out, right? We had I think, at least 6 or 7 euglycemic ketoacidosis being referred to us by cardiothoracic surgery, right? Patient undergoes CABG. Next day, right? First time this came, right? The anesthetist, was looking at the bicarbonate and was looking at acidosis. The patient continued to have metabolic acidosis, which was unexplained, right? And that is when, we came in and we, looked at the patient's prescriptions and other things. And we said, this is euglycemic ketoacidosis. We did the beta hydroxybutyrate. It was high, right? And then the cardiac anesthetist recognized, okay, this is a problem, right? So every time then he starts seeing this type of picture, he starts looking at this situation, right? And there, like I said, they picked up 6 or 7 cases where, in some of the cases that, the SGLT2 was also stopped a couple of days prior also, right? And yet the patient did develop. So again, don't take this for granted. It's a problem, right? I'll say a lot of bashing of SGLT2, right? But be careful, right? It's a very good drug, but has to be used in the right patient. Okay, right. So I think we all agree. These are the take-home messages for the first part. When you have an osmotic symptom, ongoing catabolism, HbA1c of more than 10, RBS of more than 300, pregnancy, ongoing ketosis, HbA1c of more than 8.59 with 3 or more related diabetics, consider giving insulin, right? Patient having other end organ issues, we consider insulin. Okay, moving on. Yeah. Then, of course, you're all aware about the types of insulin, right? I'll not go into much detail, right? These are all types. Now, of course, these days you also have weekly insulins, which are going to come, right? And you're going to have inhaled insulins, which are going to come in the India market very soon, right? Very soon. Okay. So these are rapidly acting insulins, and these are short acting insulins, and these are intermediate acting insulins, and these are long acting insulins. Again, for this audience, I'm sure you're all aware, right? Of these types of insulin, right? And then you have the weekly insulin, you have the premix insulin, you have what is known as a co-formulation insulin, and you have inhaled insulin, which is Afrezza. Okay, so these are the things. Based on all these things, there are these regimes which we construct: basal only, premixed, basal bolus, and basal bolus insulin therapy, which is known as multi-dose insulin therapy. So these are the types of ways in which we start the patient on insulin. Most of the time, the therapy we start as a basal insulin. And so basal and basal bolus is what we now maximum use in practice. A lot of premix also is being used even today. We'll see that discussion also. Okay, moving on. So then let's say we have all agreed to the cases of, now remember I'm focusing right now on type 2 diabetes, right? Type 1, it's a different ball game. So you have a type 2 diabetes patient and you have decided that you want to start the patient on insulin. Question is which insulin? Okay. So there is no simple answer. It would also depend on the patient's financial status. It would depend on what insulin is available, right? All the other things, right? A lot of the times, let's say you're working in a government setup or you're working in a setup which has socialized medicine setup. You have only certain types of insulin available to you. What can you do, right? You don't have a choice. So, but let's say again, you have problem of plenty. You have all the insulins available. What insulin you will choose in what cases? This is exactly a question which there's a paper by Dr. Mohan which looked at this, and they started looking at this in a mathematical manner, and they started looking at some formulas which can help you choose whether we can start a premix insulin would be a better choice, or a co-formulation insulin, or would a basal insulin be a better choice. Now, if you see international guidelines, and if you take all the insulin making companies, including the ones which make premix insulin, all of them say, oh, basal should be the first choice, which is true for a Caucasian. For an Indian patient or for a Western diet, right? For an Indian patient or a South Asian patient who are rich in carbohydrates, right? Who are going to take carbohydrates like there's no tomorrow, whether, basal insulin alone works in all of them, that's an argument, which is, very difficult. And that's why in clinical practice also, all of us would agree that all of us have seen premix insulin being used more, even though the guidelines say something else, right? Reality is something else. So this argument, if you put it in mathematical terms, what Dr. Mohan's paper and other research papers have shared is that if you have a wide differential between the fasting and the post-meal sugars, right, or the contribution of the post-meal sugar is very high to the overall HbA1c, then probably premix is a better choice, or a co-formulation insulin is a better choice compared to a basal insulin, right? So that's an essential argument. So to put that into formula, right, fasting blood sugar divided by HbA1c, if it's more than 20, there is more contribution of fasting blood sugar, so prefer a basal insulin. If it is less than 20, right, there are more contribution of a post-meal sugar to the overall HbA1c, in which case you should consider using a premix insulin, right? Again, remember these are mathematical terms. Your clinical practice would depend on your clinical practice. What I'm trying to do is trying to put it in a mathematical way. Maybe, using these tools. Sometimes having algorithms makes your life simple because you don't develop decision fatigue, right? We all suffer from a condition called decision fatigue, right? We make choices for ourselves every day in the morning. When I wake up in the morning, what I'm going to wear, what I'm going to eat, everything, and then you go to work and you start making choices for your patients, right? What drug to give, what dose to give, right? We all suffer from decision fatigue. How do you reduce decision fatigue? Put things into algorithms, right? Makes your choice better. You put this in a system, right? It says premix is better. Fine. Let's not argue. Let's put the patient on premix. Let's not think, right? So sometimes algorithms are good because reduces this type of insulin fatigue, right? Okay. So let's look at a case, right? So again, just to show you the formula, we put these formulas all in the link which you had put. You can check it out as a mini application, right? You can check it out, right? So you can see that. Okay, so let's put this in a formula. So again, you have this values, and let's go back to the formula which was there, right? That is fasting blood sugar divided by HbA1c, right? And to make things simple, HbA1c is just 10. So 189 divided by 10 is, so maybe basal insulin, right? You start, right? So this is where you take a basal insulin. Okay. So these are again useful, right? Like I said, we put these kind of formulas in the mini application where you can use. Okay. Moving on, then comes what dose to give. Okay. So we decided the patient needs insulin. Let's say we decided patient needs basal insulin. What dose of basal insulin to give? Okay. So I think the dose thing is the fundamental question, because when Benting and Bess actually started with when they first developed insulin, the first question they asked, what dose to give, right? It's always true, right? That is an era before you had all the, fancy pharmacokinetics and dynamics and all the phase 1, 2, 3 trials, right? It was a human trial or animal trial, whatever that was, right? So that's the point. So what dose to give? That's an argument, okay? So let's again put a formula into each picture, right? Now there are two schools of thought, right? This is where I often differ from most, guidelines, and this is again going to be a expert opinion rather than a guideline based opinion. Most guidelines and most remember, this is diabetes Asia study group, okay? So you're all probably traveling in the same boat, right? You're all probably facing the same problems. The problem is that most guidelines, if you see guidelines, or even if you see the recommendations from the insulin manufacturers themselves, generally it's 10 units. Start with 10 units, right? Or start some weight-based regime, which I find is probably incorrect. The reason why it's incorrect is that patients come to us in a more glucotoxic state, and patients come to us with a higher HbA1c at the time when you are initiating insulin. A global average is about 9%. Our average is 11 or 12% when we start initiating insulin, right? So we are starting insulin much later compared to what others are doing. And in that regards, what happens is that when the patient comes, they're already glucotoxic, and sometimes that slightly smaller dose of insulin does not cut the cake, right? The patient's blood sugar doesn't get controlled. And then comes the question of the patient then questioning whether insulin is the right therapy or not, right? That's the challenge. And that's why Holman and Turner actually pegged the insulin dose based on the sugar values rather than based on the actual weight of the patient, right? And this actually makes more sense, right? In most situations, you give a dose of a drug on the severity of the disease and not on weight, unless it's, of course, pediatric age group, right? Most cases, we always look at the severity of the disease, and then you probably decide the dose of the drug, right? Now, patient has a fasting blood sugar of 300. I really don't think 10 units is going to cut the cake, right? It's not. And this is the reality I'll tell you in clinical practice, right? The glucotoxicity is not going to reduce. Glucotoxicity is not going to reduce, and patient will wait for a few days. Blood sugar is not coming down. You change the doctor. Tell me how many times this has not happened. It has, right? A patient will say, "Ek to mujhe insulin diya," right? Once you started insulin, that's not working. Why should I take insulin, right? So you have these arguments, right? So that's again real life situation. So Holman-Turner formula, very easy to use. Fasting blood sugar minus 50 divided by 10. So let's say your patient's fasting blood sugar is 250. what dose you will give?
20.
20 units and not 10 units. And remember, this again fits with the fact that then you are going to monitor the patient and check their sugars. Because if you don't, if you're not going to do that, start 10 units. That's again my personal recommendation. If your patient is not going to be compliant, then assess your patient's compliance, whether the patient is going to check the sugars, patient is going to titrate the dose of insulin. Only and only then consider this. Otherwise, you will actually end up with again more trouble, right? The other side of trouble, hypoglycemia. Okay. So 38-year-old patient, right? Okay, let's sure you got the point. Okay. So yeah, so this is the, let's say patient comes with you. This is a patient comes with 316. I'm sure you've all seen such patients like this in practice, right? Every day, one patient with 500 blood sugar, 400 blood sugar, right? Yeah. So my assistant who just started working with me since 1 year, sir, kitne patient aate 400 sugar wale? I think it's a daily thing, right? You will see it in books. It is surprising. In practice, this is a daily thing, right? It's a roj ka hai, right? So that is what happens. Okay. So 400 sugar, 300 sugar, 500 sugar, right? Very common. So this patient and this patient, whatever the weight of this patient, I'm sure 10 units is not going to make any difference, right? So yeah, so this patient, right, we started again a higher dose. You can again put this in the thing, and we have weight-based calculator also. Try putting some cases of yours in weight-based versus the Hallman terminal formula base, and you'll find that sometimes there is drastic difference in terms of the dosing. And then trust me, probably giving the other formula dose is probably better because the patient's blood sugar gets controlled much faster, and then that sense helps both patient and you. Okay. So then comes titration. Okay. So you started insulin. Now how do you titrate? Again, there is a school of thought here. So most guidelines, okay, anybody wants to volunteer? How do you titrate? So let's say you started a patient on 20 units of insulin. How will you titrate the dose of 20 units of basal insulin? Let's say basal insulin glargine. We started 20 units. Titration. How will you titrate?
Based on the fasting sugar levels.
Okay. So
every
the
3
dictum
days-
is fix fasting first, right? So you check the fasting sugar, and how will you, let's say patient comes to you next day, or patient reports to you next day, or after 2 days that the fasting blood sugar is now 180. What will you do?
We'll increase the dose. We might need to wait for a day or so because the
Okay, let's say we waited for 4 days. Let's say after 4 days, patient says blood sugar is 180. It was 250. Yeah, so that's what guidelines say. Every 3 or 4 days, you increase by 2 to 4 units. Again, I differ here. I'll tell you why. That is again where glucotoxicity really comes into picture, right? So this is what I always used to do, right? See the fasting sugar, increase the dose if it's not in target, right? I'll tell you a pro tip, right? Again, expert recommendation. Works in a lot of ways. If you started a patient on X dose of insulin and the patient's blood sugar is coming down with that X dose of insulin, don't increase the dose. Glucotoxicity is anyway coming down, right? There is no hurry. There's no emergency. Take your time, right? Again, you start with a higher dose, right? But the counter argument in terms of titration is that I take it slow if the patient's blood sugar is coming down on their own, right? Or with the insulin, right? So let's say the patient's fasting blood sugar was 250. Now it's 180. I'll not increase the dose. Continue 20 units, right? You can see in this, we do this with WhatsApp, and you may do it in whatever ways you want, right? So let's say patient was 20 units. Now, when do I increase the dose or reduce the dose? The patient's blood sugar is increasing. Let's say patient is started with 200 and now it's 240. That means whatever dose you're given is not enough to curb the glucotoxicity yet. And then you increase the dose. So I say, okay, fine, you increase your dose to 24 units or whatever dose, right? If the patient's blood sugar starts going, so again, the target, again, most guidelines say target of 80 to 130. 80 to 130 is the usual target. I keep a target of 90 to 140, right? Not 80 to 130. 80 is a little bit on the red side, right? And 130 again, so kind of shift it to about 10 milligram per deciliter. So if the patient's blood sugar is less than 90, I then start knocking a unit or two off, right? And if it's more than 140 and it's not coming down, right? If it's serially coming down, don't increase the dose. And once the patient lands in that sweet spot of 90 to 140, you just leave it with that, right? Keep checking for a few days. And if the patient is stable for about 3 or 4 days with the same dose, ask the patient to continue checking, but they'll just report to you if it's out of range, right? Otherwise, you can just keep it and then call the patient back on follow-up, and then you can then do the next step, right? So that's the whole idea in terms of titration, right? How do you titrate a premix insulin, right? So this is basal insulin, premix insulin. If you're giving once a day, premix insulin once a day, like the co-formulation insulin, again, a little bit, variation, and this is what the manufacturer also apparently always wanted. The co-formulation insulin, which is very popular, Rhizodec, is, a lot of times I've seen it being prescribed twice a day, which is fine. It's fine. It's your practice in which you do. But I often recommend using it once a day, like a basal insulin, right? Use it like a basal insulin. And then if you do need a basal plus, if you need still additional, why not give a short acting insulin instead of giving both the combination? Okay. So my practice, what I do is if I start the patient on a Rhizodec, right, which is a co-formulation insulin, I started like a basal insulin before the heaviest meal of the day. Let's say 20 units before dinner. Let's say dinner is the heaviest meal. And then you titrate it with the fasting blood sugar. And if it's, I've achieved the target, I'll just wrap it up. Right? Let's say I've achieved the target, fine. But let's say HbA1c is still high and let's say post lunch is high. Instead of splitting the dose, what I do is I add a short acting insulin, a FIASP before the lunchtime. Now, why that is good? Because then I can independently titrate both the doses, right? If you give a premix insulin, if you give a combination, when you're increasing or reducing the dose, you're increasing or reducing the dose of both the components, right? And not one, which becomes very complicated. And one thing in insulin therapeutics, always remember this as a rule of dictum and as a rule of thumb, keep things simple. The simpler you keep, right? Why? Because at some point the patient will also start figuring out, okay, this is what you're doing. And then he'll start doing it himself, right? At least an intelligent one. And then he'll just stop bothering you, right? They're well managed, right? If you keep it too complicated, the patient does not understand how these things are being titrated. They'll always be dependent on you, right? And they'll have, paralysis of taking action on their own, and they'll end up in more trouble, right? Sometimes. And sometimes they take complicated decisions of their own, which is even more troublesome, right? So keep things simple. Sometimes explain to the patient that this is what we're doing. This is what our aim is, right? If the patient understands that, the patient will then start doing a few things on their own, right? For that one high sugar, they'll not bother you. They'll titrate the dose on their own, right? And correct it, right? So these are the whole idea, right? So I'll end here. I just have 37 seconds. On the system which we have put, it's there on the WhatsApp group. We also have additional things on storage about insulin and the transportation and other things which are frequently problems which a lot of us face. So you can check that out, right? And there are certain notes and applications also, so you can check that out as well. There is some material on the upcoming once weekly insulin also, so you can see that as well, right? We'll be happy to take a question or two if we have time. Yeah. I think it's now the break, so maybe you can take a question or two. Yeah.
Sir,
Yes, sir.
so if you start basal insulin, what do you do about the sulfonyl users?
Yeah, great question. I think we should address that. Yeah. So most of the time, right? If
People
a patient,
continue.
yeah, so they are the 6 milligram. And again, my rule of thumb, my algorithm is at that point of time, I cut the SUs by half.
Okay.
Whatever dose they're taking, I cut by half. So 6 milligram, I'll probably put him on a 2 milligram of SU and continue a basal insulin, right? Maybe then if I need to increase, I'll probably increase the insulin, right? So that is fine. One, again, rule of thumb, and you'll burn your fingers if you do that, don't stop the SU altogether, right? Don't, because you'll immediately so SUs, what they do is it's like a spring. They keep things under check, right? They keep it like that. And you take the spring out, right? You take that pressure on the spring out, it suddenly bounces back, right? And then again, patient goes into a glucotoxicity, and then again, you are in trouble, right? And that becomes very difficult for you to control it, especially on an outpatient basis, right? Indoor patient, fine. Outpatient basis becomes very complicated. So it's why it's very useful that in OPD practice, I often then prefer sometimes, we have a smaller dose. I prefer putting him in a glycoside, which is less hypoglycemia. So these are also few tricks of trade that you.
But then
learn.
both do the same, like basal insulin and
Yeah, essentially yes,
Same.
because it's a long-acting SU, right? So a long-acting SU is like a basal insulin in all practical purposes, right? Yeah.
both.
Yes, please.
Right now you said that don't consider increasing the dose of insulin as long as it is in the decreasing trend.
Correct.
You said if you have started at 250, now it's 180, you will not consider for how long do you wait? If it is consistently 180 a number of times, then do you really
Yeah, so that's a reduces. If it reduces, it's reducing. Then I increase the dose. Right. So if it is, yeah. So in my practice, in that initial titration phase, in my practice, again, it may differ on your practice and depending on your availability of resources. In my practice, it's daily, they have to report a fasting blood sugar daily to me, right? Now, when I say that patient's blood sugar is 180, next day it's 180 to 183, I increase the dose. I don't wait, straight away I increase, right? But if the patient's blood sugar is 180, it's coming down to 177, 176, 175, it's reducing. I'm not touching it. I'm keeping it the same, right? And because it's reducing, maybe it'll some point it'll taper, it'll get sort of fixed again. It starts a little bit on the higher side again. Again, I increase 2 units or 4 units, right? So that's a simple, again, algorithm to do, right? Also has a safety balance built into it, if you see, right? Because if the patient's blood sugar is anyways coming down, you're not increasing the dose, you're keeping the same. It's an inbuilt safety system. Now, if you go by the standard guidelines, which they often say that you increase 2 to 4 units every day, then what you're doing is even if the blood sugar is coming down, the glucotoxicity is breaking. Remember, the patient will be on other therapies also. Patient will be on an SU also. That's also working there, right? Now, breaking that down, right? At one point of time, let's say patient develops diarrhea, stops eating for a day, and maybe has a Ramadan, and suddenly patient stops eating, and then patient ends up with hypoglycemia, right? But here you have built-in check mechanism where you're not increasing the dose, right? So you're not again putting yourself in, shooting yourself in the foot. You're just monitoring it, right? So that's the whole idea. And then once the patient reaches a stable equilibrium, then I stop, patient can continue checking the sugars, but then they can stop bothering me, right? So that's the whole kind of plan that you have that, that titration phase, you do a hand holding and then leave it to them. Yeah. Yes. Correct.
Yes, sir.
$1 million question, right? So yes, 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 yes. Okay. So both, I'll answer both your questions. So let's answer the second one, which is easier to answer. Glucotoxicity is still an abstract concept. There is no clear definition of it, right? So for that abstract concept, the answer is that glucotoxicity is when you have blood sugars which are extremely high, which has started having some sort of acute issues because of the glucose itself, right? So patient developing unintentional weight loss, patient developing polyuria, the very fact that the glucose itself, the patient is developing blood sugar. And what also it does is when you have this kind of situation, it stunts the beta cell to some extent, becomes refractory, right? In that sense. And unless the blood sugar starts coming down, that refractoriness doesn't go away. So it kind of lands up in a vicious cycle where you have to then break the vicious cycle by putting. So we don't have any objective way. It's a clinical assessment, which is based on your judgment, right? So when a patient comes to me, I'll tell you a typical example. Patient who has otherwise normal sugar now develops COVID-19 infection. Blood sugar goes up, shoots up, 300, 400, right? That's, whatever earlier, the same therapy was working. Now it's not working anymore. That's classic glucotoxicity, right? So at that point of time, you break that glucotoxicity by putting the patient on insulin. Once it comes down, that same therapy starts becoming more effective. Asking to answer your second question, which is again a common question, frequently asked question by a patient: "Kab tak lena insulin? How long do I have to take this insulin?" Right, which is fair. No clear answer. It will depend on case to case basis. Okay, so let's say a patient has, an acute situation like COVID-19, acute lower respiratory tract infection, a UTI, perioperative situation. And the patient's HbA1c was fine before that, not that high. Maybe then at some point of time, you can go back to the previous therapy, right? And then taper it off and go back to the previous therapy. Patient comes with ketosis, then it's a red flag. Okay, so then what I will do is, now if the patient is fine on insulin, doing fine, okay with taking insulin, fine. That when the patient comes, then that is where I call the patient, right? And do a mixed meal stimulation test. If they find that patient is absolute insulin deficient, no question at all, the patient continues to be on insulin, right? At least from my side. Now, whatever patient wants to do, that's a problem. But my recommendation at that point of time will be, you need to continue insulin, right? However, right, if the patient has some residual beta cell function, or maybe it has improved. Remember, when your patient is in a glucotoxic state, the HbA1c sometimes may be, the C peptides may be very low, right? So again, a lot of purists in that sense would argue that, when the patient came with this situation, you should not have done C peptide at all, which is probably true, right? But once now you are in a stable situation, calm water, at that point of time, you do a mixed meal stimulation. If the patient has residual beta cell function, and then I'm not promising to the patient, but what I'm saying is that we can make some modifications to therapy, maybe then introduce a GLP, right? And then maybe then consider seeing if you can taper off the insulin, or maybe switch to other therapies if it's possible. Again, I'm also of the school of thought that an SGLT2 and GLP has intrinsic cardiovascular benefits, so these should be therapies for long term. So I then see whether I can put the patient on these therapies, but that depends on the case by case situation, right? So I say never promise to the patient that you will be off insulin, right? It depends on how it goes down the line.
The first patient, like what you showed,
Yes.
you started him on insulin, patient sugars came down.
Yeah, so I think we'll take the last question and then we'll go. Yeah.
The first patient, like you started on insulin, suppose the patient became online, HbA1c came to 7. So at that point of time, can we think of stopping insulin? And
Yes. So I would probably, right? If the patient is desirous, 30-year-old patient, I would probably consider, he can afford it. What I'll do is at some point of time, I'll put him on a, GLP, right? And then see how the insulin goes, and maybe we can reduce the, maybe focus then on weight loss. This was unintentional weight loss. You would probably gain that weight again, and then start looking at the long-term picture, right? And start looking at the cardiovascular protection and other things. So yes, it is possible in first question. And that is exactly what we did. In fact, like he said, if you do a short-term, this type of insulin therapy, after some time, the patient will, within couple of weeks, patient will be off insulin. So that is what will happen for this patient. This is exactly what happened. Yeah. I think we'll take the questions, remaining ones later. Thank you. And yeah, happy learning.
Oh, when we? 5:45 minutes. Where you are going? Yes, go. I listen and come. You stay here because I will come at 5:45. Where you are going? I'll just go around because he's very good on that. He was our teacher in Denmark. Oh, he's from UK. Oh, he is a god many times. So that's why he came. Somebody is coming here? No. You will be here only? You're going to Tata Hall? Yeah, just go around. 45 minutes I can't. I will come for from this. There? I will come here. No, from there where you're going?
Everybody who has registered for DASG school are requested to collect their pen drives for all the sessions. We have converted into PDF format. She'll give you, she'll distribute it to you. She's right here. Thank you.
Good evening, everyone. We'll wait for another 2 minutes. We are already running late. I'll try to finish the session within half an hour. We are running late by half an hour. We can wait for another 2 minutes. Yeah, so this is good to go. Good evening, everyone. At the outset, I would like to thank the organizer, Dr. Bansi Sabu sir, for inviting me for this. And since morning, this is a really interesting session. I hope everybody is enjoying this. And the most biggest difference what I find is in different conferences you have a limited understanding of few topics which goes in deep uh, length and breadth of that topic. But here what you're seeing is more of clinical approach and it's an structured program. So that makes this totally different. So let's start. We are already running late. I am Dr. Mayur Agrawal, DMD&B Endocrinology from Central India, Bhopal. So without wasting time, my topic what is given to me is diabetes management in a special situation, that is pregnancy, elderly, and in hospitalized patient. So this is actually really important topic. I would say even 45 minutes is not good enough, right? Because there are n number of guideline, n number of things which can be discussed, but I will try to summarize because our idea is to give you a brief concept of how this is done, right? So that is what we are going to do. So no financial disclosure for this talk. And as in India, we start with Badon ka Samman, respect the elderly. So I'll start with elderly only. So let's start with elderly type 2 diabetes. So let's see what I am not discussing so that you keep these things aside. Okay, so what I will not be discussing is type 1. Now you see that type 1 can be seen in any age group. It's not that young patients or the young toddler, all those have type 1. We have patients diagnosed type 1 at the age of 50, 55 also. Okay, so that is not what I am going to discuss. Or other types of diabetes. Let's say a patient presenting at 75, he may have pancreatic diabetes. So that is not what I am going to discuss. Also, I am not going to discuss the complication which are already dealt. Also, I will not be discussing acute emergency, which would be dealt in the next few sessions. Okay, so what are we discussing and why are we discussing? Why are we discussing actually this topic in the elderly? Because elderly are totally different. They have different need. They can have frequent hypos. They can have hypo unawareness, and maybe they are not monitoring so much. They are living alone. The financial constraint is there. Maybe they are having tremor. They cannot take the insulin. They cannot prick themselves. They cannot check their blood sugars. So all those things are there. And then the sleep wake pattern is different in them. And then there are comorbidities along with this diabetes also with aging. Age itself is a comorbidity. You consider this. Okay, so that's an important thing. Age itself causes things to derange, right? So they may have BPH and then you are prescribing an SGLT2 inhibitor. So that can create problem, right? Then patient can have polyuria, recurrent UTI. All those things can be seen in elderly. So elderly is slightly different, and all those things you need to keep into consideration while prescribing any medicine. It's not like you see the patient, you see the reports and you start prescribing. Important concept is to treat the patient, not the reports. Okay, so you have to examine the basic thing, everything, history needs to be taken, examination should be done, and then the investigation. Now, what's the problem? That we are directly jumping on the investigation. We see HbA1c, we see fasting sugars and all those things, and we start prescribing treatment. It should not be done like that. Okay, now another thing which I'm not going to discuss in great detail is bone health and osteoporosis. So that's an important concept in elderly patient. Now, can anybody say where you label as elderly? 50, 55 year? Anything? Anybody? Yes. So somewhere it is 65, 70, but ADA says that 65 years. So that's an elderly. So osteoporosis, the recent guideline 2 years back, they were completely updated in the ADA 2023 guideline. And osteoporosis is a very important thing which should be screened in these type of patient, and 10 years or more of diabetes should be screened. Maybe you have a normal BMD, still the microarchitecture may be defective and the patient can develop fracture. So all those things need to be seen. And very important thing is hypoglycemia. If they develop fall, then they can have some say pelvic fracture, then can become bedridden, then the bed sore, then the UTI, pneumonia, everything can happen, right? So that is very important concept. Then cognitive issues I'll be discussing. Polypharmacy is something very, very important. You should be looking at the whole prescription. Maybe somebody is prescribing them some drug which is already prescribed, say a cardiologist prescribing an SGLT2 and you are prescribing another SGLT2. Something like that happens. Okay, so you should be seeing a complete prescription because these patients have multiple complications, multiple comorbidities going on together, right? So you need to see patient as a whole. Okay, then the physical disability, all those things I'll be discussing. This is from the Diabetes Canada. So overall there is a frailty assessment. You see here 1 2 3, that is very fit, well and managing well. For them I would say age is just a number because they are fit. Okay, you can consider them as normal and you can keep them the targets as normal, whatever you do for a normal type 2 diabetic young patient, something like that. Okay, so that's important thing. See, you don't need to address everything, you need not check everything, it's not like that, but in general idea you should be having where my patient is falling. Okay, so very fit, well managing well is like they are doing everything by their own. Mildly frail and moderately frail where they need an assistant, and vulnerable is between these two categories where the patient maybe doing by themselves, but with some trouble, with some slow movements, all those things. And then this category is really important. That is 7, 8, and 9. That is severely frail, very severely frail, and terminally ill. So accordingly, we devise that what treatment should be given, what are the targets we should be keeping for them. So I'll come to that. So that's a basic concept which you should take into consideration while prescribing medication for the elderly patient. So cognitive dysfunction is there. Maybe they are taking their OHs wrongly, wrong prescription, wrong timing, multiple OHs. Maybe they are thinking this is OHA or this is an antihypertensive. They are taking it at the wrong time. All those things happen. Maybe taking twice, thrice, something like that happens. So that needs to be seen. Okay. Then self management task and the new knowledge attainment, that becomes tough. So don't give them very complex regime. You take this before this, after this will become a very troubling thing for them. And mainly they are dependent on caregiver. So caregiver should be taken into consideration. They should be told, because you may be telling them 100 points or maybe telling them 10 points and they remember only 2 points. So that's a common problem. So that need to be addressed. Okay. Physical disability, you have to see whether they can do their routine activity or not and what you're prescribing. They may have hearing loss and you're keeping on telling them they don't understand anything. They have vision impairment. They cannot see their blood sugar. They cannot adjust their insulin. All those things happen, right? And then the falls is very, very important, as I have already discussed regarding the osteoporosis. And most of this patient would be financially dependent on somebody else, maybe their children, right? So that needs to be taken care. Don't prescribe them something which they cannot afford, right? So that's an important thing. Glycemic target. So this is really important, and that's totally important in elderly patient. Okay. So this is from the ADA 2025, the recent guideline. You see here the HbA1c in the non-pregnant adult is less than 7% without significant hypoglycemia. If you can do it, that's the guideline. And for the elderly where there is limited life expectancy, then you may keep it somewhere 8. So that's the basic guideline from the ADA 2025. Let us dig deeper into this. So this is where your frailty index come into play. So let's say the patient is in first 3 categories, that is very fit, something like that. Then you can keep the same target. Maybe less than 7 is good enough for that patient also, irrespective of the age. Okay, because physically he's very fit, right? All those things are there. Functionally dependent, you can slightly relax the target, and even relax the target if you think that the patient can have hypo or will not monitor, something like that, he's living alone, or maybe there is some cost constraint, he may not be checking his sugars again and again. So that is an important thing. Frail patient and end of life, especially end of life. Let's say a patient have, say, some malignant issue going everywhere, metastasis. You know the patient is not going to live for more than 1 month, right? So he cannot develop complication of diabetes. What is your aim is that he should not develop decay, he should not develop hypoglycemia. That is good enough, because you are not bothered about that he'll develop complication, because he does not have 10 years to live, right? So that is important, that overall the life expectancy of the patient, right? So for end of life, we don't target much. In fact, some of times if the sugars are like going 220 also, 250 also, it is okay. We allow them even taking some sweets also if the sugars are not going beyond 220, 250, something like that. Okay. So don't go very stringent in these type of category. Now this is from the CGM. Okay. So like your HbA1c, you have, I think this is not visible. Just, yeah, for your type 1 and type 2, you have your TIR, that is 70 to 180, you keep it more than 70%, right? Time in range. And time above, you keep it 25 lesser, and time below range, you keep it less than 4%. I think the basic things you must be knowing. The same concept, what we have applied for HbA1c, the same thing we apply here for CGM also. What we don't want is hypoglycemia in this elderly patient. Reason being, the life expectancy is not that much. Any hypoglycemia can be end of life. Maybe he is walking through the, say, stairs and he gets a fall, he develops a fracture, or maybe in hypoglycemia he develops an MI, maybe he develops an arrhythmia. That is what you don't want. Ultimately you are preventing complication in the long run, but you are causing something very terribly acute thing, right? So that is not what you want. Same way, we don't want hypoglycemia, so the TBR should be less than 1%, and we are compromising on the time in range because we want to reduce the TBR, right? So this, even above 50% is good enough for the elderly patient. Okay, so this is very important. For old, frail patient, keep your TIR 50%. Now, this is something you need to tell your patient whenever you apply the CGM, because whenever you apply the CGM, any single reading goes higher, the patient is very worried. It's like a double-edged sword. Now he wants to know why my sugars are going 200, right? So for these type patient, don't go very stringent, because you would be causing more harm than the benefit to this patient. Now, there are n number of things which can increase the risk of hypos in these type of patients. They may have renal insufficiency, they may have autonomic neuropathy, cognitive impairment, hepatic dysfunction, alcohol intake, and therapy with SU, sedative agent, polypharmacy. All those things can lead to increased hypoglycemia in these type of patient. So you have to see all those things also, what other thing the patient is taking, and the social support is very, very important, especially in our part of the country. Okay. OHS, something which you should be taking into consideration is, do not prescribe pioglitazone if you fear for osteoporosis. This can increase. If the patient is already in NYHA class 3-4, do not prescribe pioglitazone. If the patient has history of recurrent UTI, kindly do not prescribe SGLT2 inhibitor. We are talking in elderly. Okay. If there is a strong indication, we may prescribe that, but this is a general thing what I'm telling you. If the patient is having recurrent hypoglycemia, kindly avoid sulfonylureas, and then kindly check EGFR, just not creatinine. You have to calculate EGFR. There are guidelines like below 30, do not prescribe metformin. 30 to 45, you may continue, but do not add metformin. And 30 to 50, you have to give at reduced dose of metformin. That's the basic thing. And then insulin, very important. They may have tremor, they may not have that dexterity, they may not have that acute, they may have vision problem. So keep it very, very simple. Ask them whether they can do it or not. Maybe if they cannot see, then they can count the click. All those things need to be addressed in these type of patients. Monitoring is something very important. Glucometers with a large display, without coding, easy to hold, bold numbering with memory, and CGM is even better in these type of patient. Now let's talk about diabetes management in hospitalized patients. So this is again very, very important. So why are we discussing? Again, the same question. See, everything you do in your life has a goal, right? So why are we discussing this? Why we need a good glycemic control in hospitalized patient? That's a basic thing, right? So we need, because we want to prevent the metabolic decompensation. Maybe the sugars get very high, the patient land up into DK. Maybe the patient land up into HHS. Then there are studies that it is associated with poor wound healing. If the sugars are high, infection risk increases, length of the stay, that is hospitalization, that increases. Overall survival and the surgical outcome are also dependent on the glycemic control during hospitalization. So it's an important concept that you should be keeping the blood sugars. I will tell you the ranges. You should be keeping blood sugars in check. That is what I would say. Now, there can be few possibilities here. Maybe the patient is known diabetic on treatment, maybe OHA, maybe insulin. Maybe the patient is known diabetic not on treatment, maybe trying alternative therapy, maybe just on MNT. Okay, maybe just on dietary modification, maybe undiagnosed diabetes first time presenting in ICU or something like that, where you find that HbA1c is 13 and the sugars are like 500. Maybe it's an stress induced hyperglycemia, or maybe it's a drug induced hyperglycemia, because you have given something like, say, prednisolone, something like that you have given in the patient, and then because of that the sugars are going haywire, right? So these can be few possibility in your hospitalized patient. So let us discuss few of them. So previously undiagnosed is when you have an HbA1c higher, but if the HbA1c is normal and the sugars are higher, you say it either a stress or maybe a drug induced. That's a basic concept. Okay. Now, what are the targets? Very, very important. So if the patient have blood sugar more than 140 and you don't have an HbA1c, you should get an HbA1c. If you have an HbA1c within 3 months, that is okay. But if you don't have, you should get it. That's the first recommendation from ADA 2025. Then the targets. Target should be 140 to 180. Please remember this. This is very, very important number. This was changed 2-3 times. But for past 3-4 years, this is there. In 2022, they have kept one more line that you can keep it lower down, 110 to 140, provided you're not creating hypoglycemia. And here they have removed that number, but they have written that a more stringent individualized glycemic goals may be appropriate without significant hypoglycemia if you can do it. The number are removed, that is from recent 2 years, but in general it is 140 to 180. Okay. Now let us see in non-critically ill and in critically ill. So in non-critically ill, they have given a slightly wider range. Non-critically ill, probably the patient is eating. That is what they mean, right? So this is important. Now, very, very important question. What are we going to discuss today is what should we give for the patient? Whether we should continue with OHA, whether we should continue with OHA and add on insulin, or whether we should switch to insulin. That's the basic thing what you need to answer. A patient admit हुआ है, what should be done, right? So let's talk about guideline again. So guideline says whether you're talking about a critically ill or non-critically ill individual, if blood sugars are more than 180 on two occasions with 24 hours apart, ideally you should be initiating insulin. That's a basic thing. But again, it's a guideline. It is not mandate that you should be doing this. So let us talk more detail. Now, let us first discuss that there insulin you can give either IV or subcut. There are some indication where you need to give IV insulin. So these are important things. If the patient is in DK, if the patient is type 1, if the patient is critically ill, not eating, if the patient is on vasopressor, if there is some peri-op thing, the patient is subjected for major surgery, if the patient is NPO or the patient is on TPN, all those things, then you should be prescribing IV insulin, because if you're giving subcut, probably it will not get absorbed, or maybe the pharmacodynamics will change. Right. So that is important. And then there is an indication of severe hyperkalemia beyond sugars. And very important, if the potassium is less than 3.3, irrespective of your blood sugar, kindly do not start insulin. The patient may have AF, right? Very important. 3.3, even if the sugars are say 400, 500, you cannot start IV insulin. Now, this is something very important. Anti-hyperglycemic in hospital setting, if the patient is critically ill, IV insulin. Non-critically ill is still insulin, but you can give subcut insulin. OHAs are generally not recommended, provided the patient is admitted for very small thing, maybe a cataract surgery. You can just skip and you can reinitiate it, something like that, right? Or let's say the patient is admitted for just an endoscopy. You don't need to switch everything. Just omit the morning dose, reinitiate. Okay, so we have very good guideline from the NICE. If you want, there is complete guideline for each and every drug. Again, we cannot go in that great detail. The basic concept here is to sensitize you what should be done, right? Now, let's talk. I'm giving IV insulin. How should I be giving it? What dose I should be giving it? How I should be changing it? So there are n number of things, right? So there is Portland, Yale protocol, Cup protocol, RBH protocol, and mind you, even the best in best super specialists cannot remember this. Nobody can remember all those things. Okay, so what we do is in every hospital, we create simple charts. Because see, you staff cannot ask every hour, now the sugars are this much, what dose is to be done. Ideally, this should be done by the nursing staff. So you create your own protocol depending on the availability, depending on the resource. That is what is done. Okay, so the exact protocol is not very important. An institutional protocol or an hospital protocol is what is to be required, that is need to be developed, and probably that your staff should be trained to use that. That is more important. So if you see IV insulin, how you make it is 50 unit in 50 ml of NS. So you will get an 1 unit per ml of strength, and that you can give via the infusion pump. Or maybe sometimes if you don't have then infusion pump, then dial set is something we use in resource setting. Okay, resource limited setting. And the target is somewhere 140 to 180. You can give any of the regular insulin, any brand, or you can give a rapid acting analog. See, the basic difference in the analogs and your regular insulin, or let's say any long acting insulin, they've slightly modified so the PK/PD changes. But when you're giving it in IV, it is directly going on the receptor. The half-life is just 3 minutes. Why to waste money of the patient? Just give regular insulin. The regular insulin will come at the cost of 300. The analog would come at the cost of 500 or 800, right? So don't waste the money. Regular insulin is good enough. Insulin binds to the plastic tubing, so you need to flush. Maybe 20-30 ml is good enough, and then the same you keep on changing, right? So let us see how you titrate. Initiation, there are n number of protocol. What usually is done is 0.1 unit per kg. A bolus is given. Again, that is very controversial whether to give bolus or not. Again, it's an institutional protocol. Infusion initiation, simple thing. Blood sugar depend upon 100. That is, let's say 400. You start with 4. 350. You start with 3.5. Something like that. That's the basic thing. Initiation. Now, how to adjust? So this is what we do. If you want, you can take the picture. Again, this will depend on institute to institute. So if the blood sugar are falling, say 30 to 50, I'm okay. That is what we want. We don't want a rapid correction. The patient can have cerebral edema. Okay. So 30 to 50 is good enough. And let's say the sugars were, and this is very important, like let's say sugars were 800, 900, which was not documented on your glucometer. Ideally, at the baseline, you should be giving a venous sample and you should be checking. Then only you would know that, okay, my sugars are falling by 30 to 50 because the glucometer report would be high, high, high. That's it. It will not tell you how much it is dropping. So that's another important concept. And then ketone and all those things I'm not discussing. That is again an important thing. So let's say it is falling by 30, then you don't need to change. Whenever the sugars are high, that is above your target of 180, you just keep on the same rate. And if the sugars are falling by, what I have made it very simple. You remember it 25 and 50. If it is falling by more than 25 in normal range, you reduce it by 25%. If it is falling by more than 50, you reduce it by 50%. If you remember this line, it would be easy. Otherwise, nobody can remember again these charts. Okay, so more than 30 to 50, it is dropping. That is, 30 to 50 is okay. That is what we want. And the targets are higher. You keep on the same dose. And if it is 30 or say 25 to 50, you reduce by 25. If it is falling by more than 50, you reduce by 50. That is when the sugars are already within target range. Okay, and then less than 25, here it is 10, but less than 25, we usually continue same. That is the general thing what should be done. Chinese proverb I would like to say here. मैंने सुना, मैं भूल गया, मैंने देखा, याद रहा, मैंने करके देखा, मैं समझ गया. So this is important for your hospitalized patient. I hear, I forget, I see, I remember, I do, I understand. So until you do it, you cannot remember it. That's practically. Okay. Safety indicator, when you transfer the patient from IV to subcute, whenever the blood sugar are stable for 4 to 6 hours, the patient has no acidosis, no decay, ketones in the blood are negative, urine it may be still positive. Okay, so blood ketone negative, acidosis is resolved, the patient is eating, the patient is hemodynamically stable, the patient is not on vasopressor, you just shift from IV to subcute insulin. Okay, now what is very, very important thing is overlapping. I've already told you IV insulin will work just for 3 minutes. So as soon as you will stop, the sugars will keep on rising. So you have to overlap for 20 to 30 minutes. You give the subcute insulin, you continue your IV insulin, and after 20 to 30 minutes, you stop your IV insulin. Okay. So that needs to be done. And then the dose calculation is, you can either calculate a 24 hours or you can calculate a 6 hours, and then you can multiply by 40, 80% of which you will use as subcute, 50% basal, 50% bolus. That's the basic concept. Okay. So if you want, you can take picture because I'm very, very quick because we want to finish within half an hour. Now, sliding scale is something which I thought I should be discussing. There are two things, sliding scale and the correctional dose. These are two different things. Sliding scale is you give insulin when the sugars are higher. You don't give insulin when the blood sugars are normal. Okay. That's the sliding scale. Now this should not be done. This is non-physiological. Now what happens? Let's say in the fasting, the blood sugars were 90. You have not given any insulin by the sliding scale. The patient has taken breakfast. Now the blood sugar went up to 250. Now with 250, you have given say 4 unit, 6 unit. With that 6 unit, the blood sugars are crashing to say 50. With 50, you have given something sweet or maybe some IV dextrose. The sugar has shot to 350. Now at 350, again you have given 8 unit, the again sugars have gone to 30 and maybe the patient is unconscious. So that keeps on happening. This is unphysiological. You should not be using sliding scale in any of your hospitalized patient. Now what's the basic difference between the sliding scale and the correctional dose? Correctional dose, you give a dose of insulin at that normal value also, but you increase the insulin when the sugars are higher. So that means at 90 or say 100, you will not give insulin in the sliding scale, but you would be giving in correctional dose, right? In correctional dose, you will giving a basal dose. Let's say I have written say glargine at night 10 unit and regular insulin 664. So 6 unit would be given at 90 sugars also. That's the basic difference. And let's say the fasting is 250. So in that time, both the sliding scale and the correctional dose, both will ask to give insulin, but there would be difference in the dosing. Okay, so correctional dose is allowable and advisable. Sliding scale is not advisable. Okay, the basic difference is that at normal sugar also the insulin would be given normally, and maybe you add just 0 unit because the sugars are normal. That is zero correction, but you give insulin. In the sliding scale, you don't give insulin at the normal sugars. That's the basic difference. Okay, now basal bolus is something which is superior, efficacious, more physiological. Basal will keep on a constant level of insulin, will maintain your sugars, and the bolus would be given depending on what meal the patient is eating and what the sugars are that time, because it would be different. Let's say the sugars are 100, it would be different. 200, 300, it would be different. The patient is eating one chapati, it would be different. Three chapati, it would be different, right? So that depends bolus on what the patient is eating and what is his sugar at that time. Okay. Correctional dose, I've already told you. Enteral nutrition, ideally, you should not be using insulin in the TPN bag, but that some institutes are doing because it becomes tougher for it to adjust. Okay, so ideally, continuous infusion should be going on with a different line, and the TPN should be go with different line. That is ideally what you should be doing. But sometimes, yes, in the TPN bag itself, people are putting insulin, and that goes like that. But that is not what is recommended. Tube feeding, basal bolus is something very important, and maybe say too early, 4 early also you can give insulin. So both the regimes are okay. I'm not going into details of tube feeding also, because see, you aspirate and you see whether the remnant is there or not, and accordingly you will give the tube feeding, right? So accordingly you have to adjust the bolus doses. That's the basic concept. Now let us discuss hospitalized patient on steroid. So if the patient is on steroid, depending on the type, frequency, dose and duration, how much the patient is taking, the insulin would vary. If the patient is long acting is on long acting steroid like the dexamethasone, probably you will you will require a basal insulin. And if the patient is on say prednisolone, your Visolon, Omnacotil, all those, then that half life of that drug will coincide with NPH. So in those patients, NPH would be preferred, something like 12 hour. Usually we give it post breakfast in the morning. You give insulin NPH at that time, it would cover. So whenever the patient is on prednisolone, you would have seen the blood sugar spike post lunch and pre dinner. That's the major spike what you see, and that would be covered with your NPH. Now let's discuss the peri-op management. So you have to initiate insulin beyond 180. The same thing what I have told you for hospitalized patient. Keep the target of 130, 180, and maybe 8% is something good enough to allow surgery. And this is from the cardiac surgery data. We don't have data for other surgeries, but that is what we imply on all surgeries. And depending on the type of surgery, indication of the surgery, whether it is elective or urgent, you decide that what should be done. Okay. Try to take this patient early. You don't want your patient to land up into starvation ketosis. 2 weeks of good control is something good enough. For minor surgery, you can allow metformin should be stopped maybe 1 to 2 days prior, SGLT2 maybe 3 to 4 days prior. And on the day of surgery, do not give any OHA depending on the surgery. Let's say you're doing just endoscopy, you just stop on the same day. You don't need to do anything other than that. So depending on the type of surgery, you decide that how much, whether to stop for 3 4 days, whether to initiate insulin or not. So again, there are recommendations, but again, we cannot go in that details. And if the patient is already on insulin, something reducing the dose by 20% is good enough, and you have to monitor sugar, and depending on that, you have to adjust your insulin dose in peri-op period. If the patient is NPO, he is not eating anything, glucose potassium infusion is what is required. If the blood sugars are more than 180, you can initiate an IV insulin. If the patient is NPO, no sliding scale in any of the hospitalized patient. And post-op, if the patient is eating, you can give a basal bolus. If the patient is not eating predictable, maybe you don't know how much he is eating, you can give an analog which you can give an even after his eating. So there are some analogs which you can give post-eating also. So that is what you can do. Okay, and then you can discharge on insulin or maybe oral therapy. If the requirement is beyond 0.5 unit per kg, you need a basal bolus. You should be initiating insulin. And let's say the patient is on got a CABG, major surgery. So you should be putting him on insulin for at least 2 to 3 weeks. That is what the standard protocol we follow. Now the last part and the most important part, diabetes management in pregnancy. Again, I'll be very quick. So let's start with the definition of GDM. GDM is onset or recognition of first time during pregnancy, which is not overt diabetes. That's the standard definition. Now you see here each word. Recognition of hyperglycemia first time during pregnancy. That means it was undiagnosed prior. And over diabetes is your cutoff. That is fasting plasma glucose more than 126 and your 2-hour plasma glucose more than 200 and your HbA1c more than 6.5. If two of them are abnormal, you label as that over diabetes. If the patient is already diabetic, you label as diabetes in pregnancy. And there are some cutoff for GDM, which I'll be telling you. Now, at the first antenatal visit, most of the guideline will say that you have to screen for GDM. Universal screening is what is recommended by most of the guideline, except for the NICE guideline. Woman should be again tested. Let's say the sugars are normal with OGTT in the first time, then you have to again test at 24 to 28 week. And then maybe again you have to test if you see the patient is developing macrosomia or the patient is having polyhydramnios. Now, this is what is diabetes in pregnancy. Maybe the patient is not on treatment, but your HbA1c is say 8 during first antenatal visit. That means it was undiagnosed diabetes. It is diabetes in pregnancy. GDM we have cut off. Okay, I'll come to that. So pregnancy, previously known diabetes or undiagnosed diabetes in pregnancy is diabetes in pregnancy. Now, what happens is the patient have some risk factor, obesity, ethnicity, nutrition, physical activity, genetic predisposition, due to which there is increase in glucose, triglyceride, free fatty acid, and insulin resistance is there. And this leads to preeclampsia, preterm level, stillbirth, congenital malformation, LGA baby, and birth trauma would be there because of the macrosomia. The patient develop hypoglycemia because of the beta cell hyperplasia, hyperbilirubinemia would be there because of the polycythemia, because of the large size, and then the respiratory distress syndrome can be there. So this is about your GDM, why we need to treat. This is the basic pathophysiology. Again, I am not going into detail. Because of the insulin resistance, you have higher blood glucose, which goes via the placenta to the baby, which stimulates the pancreas, leading to beta cell hyperplasia. That is why the patient or the baby will develop hypoglycemia after the birth. Okay. So now there was concept of primary prevention, secondary prevention, tertiary prevention. Primary prevention is like risk factors are there, disease is not there. Secondary, when the risk factor disease is there. Tertiary, when there is complication. So this is primary, secondary, tertiary prevention. Now what we are talking about is primordial prevention. That means when the baby is within the womb, you want to prevent diabetes in that baby. That is what we are talking about today. Okay, so that is primordial prevention in the next generation, I would say. Okay, now this is very confusing. Take a picture and you revise it, then only you will understand. So this is diagnostic criteria, n number of criteria. Let us talk just the very basic thing. If you understand that the DIPSI, the Indian criteria, they are very simple. We are resource limited setting. What we do, non-fasting patient, you give 75 gram. If more than 140 at 2 hours, you label as GDM. Less than 140, normal. No much thinking beyond that. Okay, that is very clear. Now let us talk about the IADPSG and the ADA, WHO, ES, FIGO, all those guidelines. Here, what they do is one step fasting 75 gram anhydrous glucose. And if the fasting is more than 92, 1 hour more than 180, or the 2 hour more than 153, if any one of the three is abnormal, you will label this patient as GDM. Okay. Now the ACOG comes with two-step. They say that you give first in non-fasting, you can give 50 gram of anhydrous glucose, and if that is beyond, there are different cutoff, 130, 135, 140, you take as 140. So if that is more than 140, you do a two-step test. Then in two-step test, you don't give 75. Now you will give 100 gram, and you will monitor for 4 points: 0, 1, 2, 3, 95, 180, 155, 140. And if two are abnormal, then you will label this as GDM. So what ADA did in 2020 is that they took both the cutoffs, both the guidelines they have combined. Either you can go for one-step test, which is 75 anhydrous glucose, or you can go for two-step test, that is 50 followed by 100 gram. If 50 is normal, less than 140, you don't go for the second step. Okay. So this is regarding the diagnostic criteria. Screening universal is recommended by most of the guidelines, but UK NICE don't recommend this. Screening two-step is by ACOG, ADA accept both, whether you can go for one step or two-step, that is okay. 75 or 100, 75 in both, almost all the guidelines, 100 in your ACOG. And then depending on what cutoff you're taking, point sample, fasting, non-fasting, I've already told you, maybe one sample, maybe two sample, which cutoff you're taking, which criteria you're taking, depending on that, you will label this patient as GDM. Okay. Now, this is very important. This I have taken from Amazon. Can anybody say that how to measure 75 or whether this glucon D 75 can be given to the patient for checking OGTT or not? Just raise your hand in yes. Can you just measure 75 gram of this and can you give that? Very good. So yeah, I can enlarge it. So you see here per 100 gram, if you see the carb is 90 gram. Most of us would have never read this label. Okay, so when you give 75 gram, it is not 75 gram. The correction factor is 1.1. That means you have to give 82.5 gram to make it 75 gram of anhydrous glucose. So if you are using this thing, which is available commonly, this I have taken from Amazon only. So you have to give the patient 82.5 grams. See, when you are doing so much of thing, when you are taking fluoride vial, when you are labeling that, okay, 140 I'll label as GDM and 139 I'll not label as GDM, right? You're going for that accuracy. So you need to measure this accurately. That's an important thing, right? And then there are some medical legal aspect of the same. Now let's talk about targets. So in pregnancy, the targets are totally different. Pre-meals, whether you talk about fasting, pre-lunch, pre-dinner, it is less than 95, 1 hour is less than 140 and 2 hours is less than 120. You can take the picture of this also because this is important slide. Similarly, for your CGM, the targets are different. For CGM, you see here the time in range, the cutoff are totally different. You see here it is 63 to 140. I'll just enlarge. 63 to 140. It is not 70 to 180. And for type 1, we have data to keep it more than 70%. And for type 2, we don't have data. So the recommendation says keep it high as possible. Okay. So without causing hypoglycemia, if you can maintain this range, that is what you need. 63 to 140 on CGM in type 2 patient already or GDM. Type 1, we have different, we have studies for that. Overview of the management of GDM or say diabetes in pregnancy is important thing is obviously MNT exercise if allowed by the gynae. Maybe if the placenta is lower down, the patient will not be allowed exercise. All those things you have to keep in mind. And then the very important question is metformin versus insulin, oral therapy versus insulin. I'll be discussing and monitoring and the fetal surveillance, how to do it. So MNT again, it depends on the pre-pregnancy weight. If the patient is obese, you don't allow too much of calories. And this is for the singleton pregnancy. If you have twin pregnancy, this data would change. The energy requirement would change. This is for singleton, single baby inside the womb. And then depending on the pre-pregnancy weight, pre-pregnancy BMI, you decide how much calories you have to give. Metformin. Again, very controversial. If you say both metformin and insulin comes in category B, that is we don't have much studies here, but whatever we have, they say that it is safe. We don't have dedicated RCTs, all those for this. It is non-teratogenic, safe even in IVF pregnancy, and earlier 2014 guideline also approved metformin and glibenclamide, but recently this is not an approved treatment, especially it's not first line treatment. Okay, ADA don't recommend to use this any metformin or glibenclamide. If you see metformin, it reduces the risk of preeclampsia for sure. We have very strong data for that. Reduces the risk of large for gestational age baby. Okay, so we have, but SGA baby, it can increase the risk. No increased risk of any congenital malformations. So we have MIG trial, metformin in gestational diabetes. No role in prevention of GDM because sometimes what happens that PCO patient keep on taking this. Maybe you can reduce the risk of preterm level. We have some data, especially the first term miscarriages that can be reduced, but there is no role of prevention of GDM. Overall, there is less pregnancy weight gain when the patients are on metformin, reduced dose of insulin. If you're giving metformin along with insulin, and then the less risk of hypoglycemia because you're reducing the dose of insulin, and maybe the less risk of neonatal hypoglycemia because you're overall reducing the glycemic. Okay, so glycemic load is reduced. Better patient acceptability because you are comparing here an injectable therapy versus an oral therapy, but higher failure rate, that is from the MIG tofu trial. Okay, so MIG is your metformin in gestational diabetes. Tofu is your the offspring follow-up, TOFU. So these are two trials actually. I've combined them. So 750 GDM patients were taken and metformin versus insulin alone. Metformin plus insulin versus insulin alone. There was no difference in the neonatal outcome. Hypoglycemias were lower in metformin because low dose of insulin was required. When you add metformin to insulin, preterm birth delivery that was higher here, and children exposed to metformin at 2 year and 7 year, not much difference was seen with few parameters. I'm not going into details, but at 9 years there was significant difference. So probably the baby is born with lesser weight, but that gains rapidly. That is what this trial is showing us. Now let's talk about insulin. So Lispro Aspart regular insulin is approved for the longer acting NPH, and Detimir is approved. Glargine can be continued. Do not initiate in Glargine in those patients who are GDM, and Degludec has been recently approved in these patients in pregnancy. Now let's talk about steroid in pregnancy. This is just last 2 minutes, I would say. So ensure glycemia is well controlled before giving steroid. If possible, increase the basal dose if the patient is already on insulin. Correction dose is needed as per requirement depending on the sugar, right? Monitor glucose more stringently. A CGM would be even preferred in this type patient, and maybe some 3 to 5 days is what you see the effect of steroid. You will require a higher dose of insulin. HbA1c in pregnancy is fallacious because of the hemodilution, but in first and second trimester, we have data that it is associated. It has some correlation with the fetal loss and malformation. And ANC measurement of this HbA1c should be repeated in the first trimester. Okay. Fetal monitoring, you have to look for macrosomia, and that is through your abdominal circumference. If it is more than 75 percentile, a more stringent sugar control is required. Now let's talk about the labor. So high rates of preterm in GDM is spontaneous abortion because of preeclampsia, nephropathy, and the obesity. And usually gynec would say that at 38th week, when the fetus is mature enough, you should go for either LSCS or induction of labor is also possible. It's not that all these patients should be subjected to cesarean section only. If there is indication for cesarean, it's not the glycemia. Okay. Neonatal management, hypoglycemia is what you should be looking at. Hypocalcemia, RDS, hyperbilirubinemia, macrosomia. Usually the definition is more than 4.5 kgs, but in India, what we say is 3.5 kgs because our babies are usually lesser weight. And then the congenital heart disease also increases. So all those things need to be screened in these babies. Postnatal management for the pregnancy, you should allow breastfeeding. Usually metformin is excreted in the breast milk, but it is pretty safe. OGTT should be repeated in 4 to 12 weeks. And then every year for lifetime, you should be screening because these patients within 30 years, that's what the data says, almost everybody will develop type 2 diabetes. So lifestyle modification and MNT is what we say to them, especially once they wean off breastfeeding, then you can restrict the calories. Okay, so risk of future GDM and type 2 diabetes should be discussed with this patient, and preconceptional care for the next pregnancy should be told to them in great detail. Thank you very much. I have taken much time. I think you can just display the last page. I have put a QR code. If somebody wants, can ask the question later on. We are already running late.
Good evening. I've got 45 minutes now to talk about cardiovascular risk and obesity in diabetes. Um, I'll try to make you think, not give you answers. And if you are able to reflect on it, that will be helpful. I think it's not me at the moment. So my name is Atul. I'm endocrine consultant in South Wales. They're trying to find my presentation deck, and I'll be talking about evidence-based diabetes care, addressing obesity and CV risk. Okay, thank you. So during next 45 minutes, I'll be covering CVD risk assessment, obesity and its complication, and the therapeutic options which are available. I'll be asking you questions, so pay attention, people on phones and all, I'll be pointing them out. If I ask you one simple thing, you know, and it's time to reflect. If we don't die of an accident, poisoning, self-harm, or don't develop cancer, it's going to be CVD which is going to kill us. Statistically, the chances are high. I'm not talking about people who are very young in here. I've reached the sixth decade of my life, so probably when I think about it, this is something which is preventable. And I'm sharing title of a book, Atul Gawande, my namesake, who's 100 times more rich than me. And I don't know if any one of you have read this book. It's deep, it's nice, must read, along with Paul Kalanathi's book on When Breath Becomes Air. Globally, we know 1 in 10 people aged 30 to 70 die from cardiovascular disease. CVD remains a preventable reason of premature morbidity as well as mortality. My sessions are mostly clinical scenario based. I'll ask you to do the hard work here. You're sitting in a clinic, you see a man of the same age as I am, has background history of type 2 diabetes, which was diagnosed around 10 years ago. BMI is 32, slightly more than mine. So blood pressure 148 by 86. I've given you the cholesterol readings and triglycerides. Have this scenario in mind and give me answers, or at least think about it. What do you think was the CVD risk for this gentleman? You can write it down. You'll get the answers in next few slides. A man, 53-year-old, and what should we do to mitigate these risks? Right? Couple of slides on the theoretical part of it, and this is my favorite slide. For the reason I know atherosclerosis is a multifactorial process. It starts quite young age. In fact, in teenage, there can be atherosclerotic plaques in people with familial hypercholesterolemia. This risk is in a continuum, and we need to be mindful of a lifetime risk approach. Higher the baseline risk, earlier intervention being beneficial. If you break down everything related to CVD, it's atherosclerosis. So, for example, if I get a medication which can keep your LDL at 0.1 for as long as possible, probably from age of 1 or 2, you live far more longer if everything else is taken in account. I didn't ask them to do this celebration, but yeah, that's fine. There is a beautiful concept which is coming in. Similar to PEC years, we need to calculate our LDL cholesterol PEC years also. How long LDL has been high and how high it is. So if you keep it in mind, it will be much easier to deal with CVD. Very soon I'll be starting to, dance and now CV risk assessment, when to screen, when not to screen. I think we can start to. So we need to not screen people who are young with no CVD risk. We don't need to screen people who are young in age or over 80, because over 80 the risk is bound to be there. The strongest risk for CVD remains age, right? So it's inevitable to get atherosclerosis once you are older. We don't need to screen people with type 1 diabetes or type 2 DM with end organ damage because they are high risk to begin with, right? We don't need to screen people with kidney disease. Most of the data which we have derived for the CVD risk assessment comes in from the Framingham study. It's a beautiful prospective study which was started in 1948, still churning out papers. And it was only 1960s in which Framingham study provided us with the data about smoking being a risk for CVD. Prior to it, we didn't know. There are multiple risk engines which are used. In UK, we use QRisk3. The slide here mentions about QRisk2, but that's more in primary care. But a QRisk3 engine is available online also. And it's quite surreal if you try to do your own CVD risk assessment using this risk engine. It takes into account your ethnicity, your socioeconomic status, multiple other factors. There are multiple risk engines, and I think in Asian population also in most of the countries we practice, we should adapt one of the CVD risk assessment tool, which we should propagate and spread to the general population. People should be doing these engines, using it online, doing their own assessment. Only problem is that there are CVD risk modifiers. So if you see somebody with autoimmune condition, SLE, rheumatoid arthritis, Sjogren, they are at high risk to begin with. People with CKD I mentioned about, being from lower socioeconomic strata itself is a risk. Having family history, especially familial hypercholesterolemia or similar disorder, your CVD risk is high. And I mentioned about these risk engines. Most of them give us a 10-year risk estimation. More importantly, we know there is a lifetime risk assessment which needs to be carried out. Most of these risk assessment engines or tools underestimate the risk if it's a female or somebody who's young, relatively young. So anyone in your clinic, if you want to do a CVD risk assessment, one alternative, use one of these validated risk assessment engines or try to assess a lifetime risk. And this is a paper we wrote more than a decade ago in which we advocated a lifetime rather than a 10-year risk assessment, which tries to ration the use of statins, nothing more. Multiple biomarkers. I'm an endocrinologist. I'll not talk more about apolipoproteins. There is more and more stress or emphasis by the lipidologist that we should be measuring apolipoprotein B, which is far more accurate than LDL or non-HDL measurement. We've got multiple lipoproteins. Every lipoprotein has a single apolipoprotein B. The higher the number, higher the risk. And it's more accurate for CVD assessment. Hopefully in next few years with more development, we'll be measuring apolipoprotein Bs. High sensitivity CRP can be measured. There is something known as LP little a. And in people with early cardiovascular disease which is running in the family, it's important to measure it at least once in lifetime. Lipoprotein little a. CA scoring and all, I'm not going to go into the details of it again. It's more a topic for cardiologists and availability of resources. And I love this slide for the simplicity of it. I practice in an area in which I can do the genetics for familial hypercholesterolemia, for familial chylomicronemia syndromes. There is no dearth of resources in place where I practice. But there are areas in which, despite the prevalence of diabetes being high, resources are limited. So if you see somebody with, type 2 diabetes and you're thinking about life-saving measures, simplest thing you can do, start metformin, a statin, ACE or ARB. You've done your job. You have already increased the lifespan of this person by using medication which will improve glycemic control, lower the non-HDL cholesterol, and control the blood pressure. If you've got more resources, you can do more things. So Often in my clinics, people come in and ask me, I'm not going to use statin. Statin kill, statin lead to dementia, statin lead to this. I get aches and pains with statin. Statin has destroyed my liver. So the evidence of lowering LDL cholesterol is unequivocal. It's driven by multiple RCTs and meta-analysis. Everything is cause and effect, and it's cumulative. And there is a whole lobby which disagrees with us. I think statins have been instrumental in lowering the CVD risk over a period of time. I did ask you about CVD risk assessment to begin with. I'm giving you a very simple slide, which is from the EAS and ESC, European Society of Cardiology 2019 guidelines. And make a mental note of it. You've got somebody with diabetes in your clinic who has end organ damage, and end organ damage can be retinopathy, nephropathy, neuropathy, anything. They are, to begin with, high risk for CVD, irrespective, period. In addition, uh, you can focus on FH also, familial hypercholesterolemia, at least in the part I practice in, is common in 1 in 300 people. I keep on reading people dying early in life because of a cardiovascular event, but we don't bother to check their non-HDL cholesterols or LP little a's, or think about the cumulative burden of these apolipoprotein Bs, right? So this simple slide I often use in my clinical practice because it risk stratifies CVD based on some of the things which we have discussed so far. Earlier this afternoon, I did ask questions. I didn't give answers. Um, what should be our non-HDL or LDL cholesterol targets? In high risk or very high risk patient, the target should be less than 1.4. If you convert it into milligram, it's under 54, and high risk is under 70. As I said, I'm not making it up. This is all evidence-based. This is from ES and ESC 2019 guidelines. If people are having recurrent CV events, the target is even lower. It's under 1 millimole per liter, which is around 35 to 40 millimole per milligram per deciliter. So think about it. Often I get WhatsApp messages from my relatives or friends from India saying, oh, my cholesterol is perfect. But when you read the LDL values for them, it may be 80 or 90. The perfect is because the lab gives you a range kind of, which is not individually applicable, right? So these are the targets which you need to follow. Coming back, again, we are reaching late evening stage at the moment. I need to keep you awake. Read the scenario, try to find answers and tell me importance of lowering triglycerides. So you see the same individual I mentioned, 53-year-old, has type 2 for 10 years. You're focusing on LDL cholesterol, which is 116 or 3. What should be your target now? I've just covered it. Is it high risk? Yep. So high risk target is brilliant. What about the triglycerides? We have covered the LDL cholesterol. Often in clinical practice, I'm asked this question, oh doc, my triglycerides are high, what should I do? What is the first thing which comes to your mind?
After correcting LDL, we had to focus on.
Exactly. Thank you, Ram. Thank you. So when I'm looking at the triglycerides, the only thought which comes to my mind is, what is triglyceride? 3 fatty acid linked with a glycerol, part of our chylomicrons, which carry the extra nutrient from intestine to the liver, and the liver is churning out some triglycerides. So they are part of lipoproteins which are lipid rich. So my first question is, number one, how severe it is. Mild to moderate. Severe is more than 10, or multiply it with, I've given the range here also. In UK we follow millimole per liter, but severe is more than 885, which is more than 10 millimole per liter, right? Now, second question, what is the reason for it? And the reason we categorize between mild, moderate, and severe is severe hypertriglyceridemia, higher risk of pancreatitis, right? CVD risk, we can talk about it. I can have a full house debate about importance of lowering trigs, how much we need to lower. Second question, what is the reason for it? If I've got somebody with high LDL cholesterol, I know I need to look for familial hypercholesterolemia or similar disorders, right? Chances of finding familial hypercholesterolemia is 1 in 300 to 1 in 500, depending on the population you work in. For the triglyceride monogenic part, it's extremely rare. FCS or familial chylomicronemia syndrome is present in, let's say, 1 in 400,000. But there is something known as polygenic or multifactorial chylomicronemia syndrome, which is far more common, 1 in 400. It's smaller mutations combining together. You'll get everything in a PDF file. At the, in a small print, there are some genes which I've mentioned. Normally for familial hypercholesterolemia, I carry out genetic analysis, but for high triglyceride, I only screen for FCS if the triglycerides are over 10 and there are no secondary factors. FCS presents very early in life. By 10 or 20, it's through autosomal recessive mutation. It's very aggressive. People get recurrent acute pancreatitis episodes. Now, one thing which I want to ask you, which has therapeutic relevance, and if you have lowered the LDL using statin, are you going to use fibrate, omega-3 fatty acid? Do they really benefit? Yes or no? Does lowering triglyceride help in reducing CVD risk? This is my question too. Very simple. Do you think lowering triglyceride lowers the CVD risk? Yes or no? Yes. Okay. Anyone says no? Most of the evidence for lowering triglyceride and improvement in CVD risk comes in from observational studies and Mendelian randomization studies. But strangely enough, if we have tried to lower the LDL, the triglycerides using fibrates and omega-3 fatty acid, apart from one which I'll mention, icosapentaethyl, there is no CVD risk reduction. Strange. That's why what Dr. Ram mentioned about that if you see a patient with diabetes, try to optimize the glycemic control, try to reduce the non-HDL cholesterol, and then if everything is constant, try to lower the triglyceride. Don't jump into lowering the trig to begin with. Apart from fenofibrate field study, which led to reduction of diabetic retinopathy, there is no evidence that there is CVD benefit. It's only recently now that icosapentaethyl, which is icosapentaenoic acid, which is showing some CVD benefit, but that's independent of triglyceride lowering. Vascepa is the brand name for it. So very interesting. For FCS, there is a medication which is, approved by EU, not in by the FDA to my knowledge, because it messes up with platelets, volensorsen. So I had a patient with MCS now, the multifactorial chylomicronemia syndrome, genetically proven, very recently diagnosed. I wanted to use this medication for that gentleman. One, it's very expensive. Second, I need to monitor the platelets every week, kind of. So it was me who had developed cold feet on thinking, oh, I don't want to have platelets monitored every week for next 3 months. Volensorsen is a medication which is approved in EU for lowering of triglycerides. In FCS, nothing else. Don't try to do it in general practice for um, your secondary hypertriglyceridemia, which are far more common than FCS. Okay, so I've spent the first 20 minutes of my talk talking about how to calculate CVD risk. I've mentioned about how to, monitor it, how to assess it, how to risk stratify. Mentioned something about trigs, which is a topic on its own. Let's move on to obesity. What do you think? What does the house think? Is it a disease? Is it a single entity? What is the problem in here? How do we define obesity?
The disease.
It's a disease. It's a chronic disease. Do you think it's due to some kind of genetic mutations? What are the genetic mutations we know of at the moment? A very small proportion of obesity is because of genetic mutations, and that's usually which presents very early in life, childhood hyperphagia, hypothalamic disorders, right? So there are small proportion of people, young adults, who will present to pediatric endocrinologist or come to your clinic who can't stop eating because there is a pathway defect in hypothalamus. One myth in clinical practice is it's the thyroid which messes up with uh, obesity, and I get lots of referrals and phone calls. It's my thyroid which is underactive. No, the role a underactive thyroid gland plays in obesity is minuscule. Cushing's disease, yes, can lead to it, very aggressive, but there are other telltale signs which are very clear and prominent. So if you see an individual who's 30 to 40-year old and obese, highly unlikely it's a genetic condition. You can check the thyroid function, correct it. That's an easy win. Cushing, highly unlikely because more likely it's going to be pseudo Cushing, which mimics it. In clinical practice, when we did an observational study, only 1 or 2% of people labeled as type 2 with other clinical signs had some element of hypercortisolism. So I don't routinely screen for these conditions in an obese individual. Okay, let's move on. Um, what do you think leads to obesity? In the part of world where I practice, it's a disease of affluence. Oh, sorry, poverty. In the part of world we live in and doing a lecture, it's a disease of affluence, right? So, in nutshell, it's caloric surplus because human beings have, forgotten to eat based on their hunger reflex. We eat based on our appetite, go out, things will be available, and we'll be on a routine eating, but we've forgotten to be hungry to eat. And anyways, I'll not go into the details of it. When I started to practice, and I'll tell you, there are three eras of diabetes management. Most of the evidence we follow at the moment comes in from UKPDS, which was a prospective trial for type 2, and DCCT for type 1, right? Early evidence. From 95 to 2010 odd, I call it a era of doom and gloom. Every single trial which we did, name the trial, Accord, Advance, Veterans trial, everything suggested if we lead to hypoglycemia, there is worse mortality. So after the initial euphoria of DCCT and UKPDS, every single trial, if you read between 95 to 2010, and then came a medication known as rosiglitazone, which we started with lots of enthusiasm and ended up with lots of heart failures. It's And in 2004, I'm quoting a paper here that life expectancy for people with diabetes was lower than general population by about 15 years. I think suboptimally controlled diabetes still holds the same kind of value. It adds on 10 years to your vascular age. Then come in from 2015 onward, what I call as a hope and optimism era. I remember coming to India a decade ago, and I was one of the speakers invited by AstraZeneca to launch dapagliflozin, and we didn't know much about this medication apart from its role in, some element of glucose loss through the urine. If I had gone to sleep in 2015 and woken up a few years down the line, I would have been surprised why SGLT2 are being used by my cardiologist and nephrologist friend in non-diabetes population, because in 2015 we didn't know about it. Another big thing which has happened in last few years has been incretin therapy. And you would have attended multiple session on how incretins work. And I think part of the reason why you get educated about SGLT2 and incretin more often than other thing is pharmaceutical bias. They've got the medication, they need to sell it, they need to tell the consumer what it means. So I'm talking about the journey of how incretins have evolved over a period of time. I remember using exenatide, which was leading to granular kind of formation at the site of injection. We were happy to use liraglutide once a day, and then came in dulaglutide and semaglutide once in a week kind of preparation. There came a time in 2021 when Western Europe and US ran out of uh, Ozempics. The simple reason for that was that it was being used so much for cosmetic reasons in private sector. It was not available in National Health Service. NHS ran out of these molecules. So as the things stand, anti-obesity medications which are available in UK, and I'm only talking about anti-obesity, I'm not talking about diabetes. So people with increased BMI, plus minus comorbidities, without even having diabetes, we can use high dose of liraglutide, comes in under the name of Wegovy. We get, no, so liraglutide is, yeah, semaglutide and tirzepatide Monjero. Wegovy is semaglutide, sorry. Wegovy is semaglutide. Liraglutide is Saxenda. I've not used it for a long time, so I'll not be mentioning about it. It's the tirzepatide or Monjero, which is showing promising results. Try to, read few of the names in here, and this is the slide I prepared around a fortnight ago. These are the anti-obesity medications which are in pipeline, which include oral non-peptide GLP-1 receptor agonist. There is a dual amylin and calcitonin receptor agonist coming up. Lots of waves being made by amylin agonist again, and the 3G molecule, retatrutide. So mark my word, watch this space. Management of diabetes is going to change over the next few years. I'll come to it. I'll try to sum it up. This is a single slide. You'll get a copy of it in your, there'll be a flash disk which will be given to you. On December 20th, 2024, Redefine 1 trial top results were announced, which mentioned that combination of cagrilintide and semaglutide. Cagrilintide is amylin agonist, showing promising results. If you look at the baseline body weight in here, 106.9, in people without diabetes, after 68 weeks, 22.7% average weight loss, mean weight loss. Jan 24th, which was 3 weeks ago, another top line result comes in for amycretin, amylin receptor agonist with GLP-1 receptor agonist. Phase 1B and 2A results, mean baseline weight here is 92.7 kg. Think about it. It's not, it's at least 10 kg lower than the previous trial results I've shown. 22% weight loss on 20 milligram dose at 36 weeks. So one of my students who did a MSc dissertation, Dr. Wael Sidrak, very bright boy from Egypt, he wrote a paper published in IGM, Indian Journal of Endocrine and Metabolism, published last year. We looked at how glycemic control gets altered by weight loss. If you're losing around 1 to 5%, zero is an error kind of, some weight loss, it improves your glycemic control. Weight loss between 10 to 15% has a disease modifying effect. Lose more than 20%, you may put diabetes in remission. Very interesting data. In my first session also, I did share with you the same kind of concept, that we should not take diabetes as a single entity. If we've got an opportunity, we should focus on weight loss. How we do it is different. I know there is limitation of availability of medication at the moment. It's only Ribelsis which is effective, which is available in India at the moment. And I know of people who have smuggled it from other routes, from Dubai and other, to use injectables also. I know of some people who have approached me about, using GLP-1 receptor agonists. As the things stand, one of my third year medical student is doing a project on 150 patients on tirzepatide, which we started last year. Hopefully by next couple of months, we'll be presenting our data in a national meeting. Very busy slide again. I'm not going to go and read every single thing. If we think about obesity challenges, one huge impact of lifestyle factors. We still don't know about the genetics of it. There are some kind of hypothalamic disorders which affect people at a younger age group, lead to hyperphagia. There is a medication available for it known as setmelanotide, which is approved by the NICE for use in people with some kind of uh, melanocyte, melanocortin 4 receptor defects. Setmelanotide, approved by NICE, but genetically confirmed hypothalamic obesity, right? In Western Europe, in UK, we are using GLP analogs. I've stopped saying only GLP-1 receptor agonist. I'm using incretin word more often because we are getting dual incretins and a triple agonist is in pipeline. The problem we are facing at the moment is moment you stop the medication, the weight gain and the glycemic control may deteriorate again. There are problems with side effect of these medication also. There is something known as Ozempic phase. They lose muscle mass. And there are phase 2 trials going on in which they are trying androgen receptor agonist for it or myostatin agonist phase 2 at the moment in which they're giving a GLP-1 analog along with a myostatin agonist or androgen receptor agonist. So too early to comment on it, but weight loss, muscle loss, and side effects, cholelithasis. Pancreatitis is not as the signal for pancreatitis is very weak. Medullary thyroid cancer seen mostly in animal models, not in human studies. So the challenges we face are multifold. I'll spend 2 or 3 minutes here to share a personal story about a patient who I looked after. I saw him from 2005 onward. His name was Mr. RP. He was quite a tall, very gentle kind of individual, used to attend the clinic, sitting in a corner, not uttering a word. When I put the story together, kind of, he was diagnosed to have diabetes in 1990 when we had sulfonylurea and metformin and insulin available. In 2002, he developed peripheral neuropathy, which went on to develop foot ulcer, osteomyelitis, Charcot's foot in 2012. Mr. RP developed a cerebellar infarct in 2016, aged mid 50s or late 50s, and after 6 months of rehabilitation died. It touched me because I had looked after him for 10 years from 2005 onward. I thought about him and reflected on it. If there was something I could have done, and you can only come to know about these things when you have practiced enough, because we meet people at a single point of their life. We don't meet at, we can interact multiple points, but when we meet them, it's a single point. If something could have been done for Mr. RP, it would have been in the green zone. Once he moves into the complication zone, you are putting in more effort, more resources, outcome you get is less. And part of the reason you are part of this DASG group, Diabetes Asian Study Group, is to promote diabetes related education, improve research, collaborate together. You are advocate for something which works, right? you'll not be able to deal with more than one patient at a time or maybe 50 in one day and multiply it. Your role is about spreading awareness which is factual, evidence based, not based on WhatsApp groups. And there is a university also, WhatsApp university, I've heard, which advocates cure of type 1 without insulin by doing yoga, right? So the key messages: CVD risk are multifactorial and often progressive. You need to identify them, individually mitigate them. In diabetes, please shun the glucocentric approach. If you've got somebody with diabetes, focus on giving a statin, metformin, ACE, ARB as the circumstances are. If you ask me about it, can I predict future? Nope. But if I have a crystal ball, I can tell you that very soon these anti-obesity medication, if they become less expensive, more freely available, can change the landscape. If I can bottle in lifestyle measures and try to sell them and patients follow it, that's probably a better medication than anything else. This is me, who was a lazy guy at age of 39. Age 51, I completed my first um, sprint triathlon. That's not a long distance. Swimming open water for 750 meters, cycling for 20K, and then running for 5K. I'm planning to continue to do it till I'm 55 or 60. First goal is reaching 55, not very far. You need to be advocating the same thing, if you're practice what you preach. So I'm sharing a slide with QRisk scoring, how to carry it. It's online, it's freely available. You can use it, test in your own self. I'll use the next 5 minutes or so to test if you've imbibed what I was going through and if you've retained things also, right? CVD risk for this woman: 48, type 2, has rheumatoid arthritis, which is autoimmune. High risk, very high risk. What is your answer? Okay, high or very high. It's fine. Guidelines are for guidance. They don't bind us, right? So high or very high, that's fine. So what will be the most appropriate step to reduce our CVD risk now? Forget about diabetes now. I'm talking about which out of these 5 will be the most useful step to reduce her risk. We discussed statins, statins, statins. You can add in Bempi if it's not being controlled, and use the celebrated placebo ezetimibe if wish to. Correct, statin. Very simple message. I'm not a complex person. I want to give you something which is very simple here. Second question: 35 on metformin and atorvastatin. Cholesterol levels have been controlled now. They are, you know, um, in the safe risk, right? If he was high risk with type 2 and had retinopathy or something, you have lowered it enough, right? Triglycerides are high. HbA1c is 50, right? So please remember this scenario and try to answer the next question.
Fenofibrate because retinopathy.
All right, okay, I'm not committing to fenofibrate. Maybe I'll not ask. His HbA1c is 50, right? BMI is 28. So which medication will be helpful to reduce his CVD risk? I've optimized the glycemic control. Icosapentaethyl. I'm a bit cautious about interpreting the data of icosapentaethyl because it comes in from 2 trials. One was JELIS trial in 2009, which was carried out in Japanese population. There was another REDUCE-IT trial. Results came in 2018 or 19. It needs to be analyzed in further detail. But icosapentaethyl, as the thing stand, is approved by NICE for use in this group of patients, right? Correct. Third question. So 42, type 2, reviewed on your clinic visit. HbA1c of 8.7%. You start thinking about giving him a GLP-1 analog, right? Patient can afford it. You want to change the outcome. Which of these is a known side effect of semaglutide or a liraglutide. C. Cholelithiasis. Pancreatitis signal was very weak, right? Medullary thyroid cancer in animal models, not in human studies so far. 17-year-old admitted to emergency with acute pancreatitis, recurrent episodes of abdominal pain. I'm taking you towards a diagnosis of FCS, familial chylomicronemia syndrome, very rare, 1 in 400,000. Trigs, very high. You keep him nil by mouth. Om was discussing a case earlier in which he mentioned about, choice between insulin or anything. High trigs need insulin, need starvation. You need to give rest to your liver and gut. Okay. So, which medication out of the following, if you're paying attention, you will be able to answer it. Valensorcin. Last question. 15-year-old boy referred from pediatric endocrinology clinic. This is the typical way they present: morbid obesity, delayed growth, hypogonadism, delayed puberty and growth, everything. Endocrine hormone assays a bit deranged. MRI PET rules out any structural lesion. And you do the testing for him. He's got POMC, pro-opiomelanocortin gene mutation. Which out of these is approved treatment for such patients? Setmelanotide. Well done. Thank you. So, okay, thank you. Any questions? We'll take the questions in the end, I think. I'll pass it on to Dr. Ahmed. Let me introduce Dr. Ahmed Al Sharifi. He's a UK trained consultant. He's left us for greener pastures. He's working in UAE at the moment. He teaches in my course for last 7-8 years. He's co-authored the book with us. His lectures receive a rating of 4.8 out of 5, highest rating for specialty trainees. That's the reason I requested him to fly in. He came in at a short notice, landed in Ahmedabad yesterday night, and will be flying back tomorrow morning. So he's here purely for educational purposes. Over to you, Ahmed.
Right, thank you very much. I find it very hard to impress the audience after that excellent talk by Prof. And I find it very difficult to talk. I know we are over time. Maybe I'll try to finish early if I can, maybe in 30 minutes time. I'll be focusing, talking about acute complication of diabetes, focusing on hyperglycemic emergencies. Start with the first slide. So these are my disclosures. So mostly I'll be trying to make it more practical, but these are the good guidelines if you want to look at. This is recently published, like June 2024, consensus report from the UK, from the American as well. But we follow the JBDS inpatient guidelines, which I was part of the writing committee for some period of time. There's a DKA guidelines, HHS guidelines. If you're busy working in emergency department, you don't know what to do, just Google JBDS, IP, HHS, DKA. You'll find the guidelines very easy and simple to follow. I'll start with a story, and this is a real story. This is Christine. She died because of diabetes. She's young, she's 21, she has 2 children. I was the registrar on call on that night. I know she was moved to the ward, and I was told she has DKA, which has improved, and she's moving to the ward. So I said, fine, thank you very much. Next day, a cardiac arrest happened, and she passed away. That was when I was in Sunderland Hospital. What happened is a complication of diabetes, is a complication of treatment. This young lady shouldn't be died. So she should be alive. It's preventable. I'll talk to you through the presentation, and at the end of the slides, we will talk what happened to Christine. Because it's an education, it's for everybody. We know incidence of diabetes increasing, increasing lifestyle. We don't walk that much. We don't sedentary. So there's a lot of reason why there's incidence of diabetes. And you've seen a lot of patients coming through the door with diabetes or its related complications. This is the only boring slice, and then we'll talk to the fun. Frequency hyperglycemic crisis is increasing. Many patients are presenting with DKA, HHS, or mixed picture. So I'm sure if you're doing an emergency setting, you'll see a lot. You'll see high blood sugar, and you want to navigate and find out what's happening with those patients. The trend in hospital admission with DKA has increased a lot for type 1 and for type 2 diabetes. And you can tell type 2 diabetes, given the SGLT2, there is increase in number of DKA associated with them with normal glycemic control. But you can tell it's more than type 1 diabetes, but it's happening also in type 2 diabetes. So you still find DKA in type 2 diabetes. And also we had COVID, we hit us very hard. We know many patients were given, the COVID itself causes DKA, and COVID treatment, hydrocortisone, in some places they use even methylpred, they could cause hyperglycemic crisis and DKA. And this is the red line during COVID pandemic, and this is all the years before COVID. And you can see the rate of hyperglycemic crisis increases after COVID and through the first wave, second wave also. And also, yeah, you have the mortality increasing with when you have diabetic emergencies. Now, to start simple, I don't like talking theory, but just this slide is very important. You just need to know the action of insulin. Insulin is an anabolic hormone. This is from Davidson, I'm sure you know about. Insulin goes to the muscle and build up prevent proteolysis and build up glycogen in the muscle. It goes to the fat cell, build a triglyceride, and prevent the fatty acid from generation, and go to the liver and build up the glycogen. So if you understand that, that's you know why insulin, the minimum amount, prevent the lipolysis. That's why patients with type 2 diabetes, they don't lose weight, while the type 1 diabetes, they lose weight and they find emaciated when they present. This is from the consensus. What's happened when you don't have insulin on board? If you have absolute insulin deficiency, you have low glucose utilization, increased lipolysis, increased free fatty acid, you had high ketones and ketoacidosis. On the other hand, while if you have relative insulin deficiency, you're more prone to hyperosmolarity and hyperglycemia as well. So you can see the wide spectrum of both DKA and HHS by understanding the insulin. Now, we're talking about some stories and some real example. This is very easy. It's just to generate discussion, really. So I'm inviting you to meet Tim, who's 21 years old, type 1 for 10 years. He was unwell, vomiting all day. He was partied a lot on Saturday with his friends. Slept all Sunday, no food, no insulin. He came very unwell to the emergency department. You did some examination. You found him extremely dehydrated. Blood pressure 90/60. Heart rate is high. Saturation okay. Temperature is fine. But you did a blood gas when you found the blood glucose 29, and that's around, I don't know, 300, 400, maybe more than that. The pH is low, 7.2, and the basic says is -10. You've checked the ketones, capillary ketones, it's 6 millimole. All the other bloods are fine, but you've sent them all. White cell slightly raised, and as you see, he has acidosis and the ketones are high. So no prizes for guessing. Do we know what does he have? Yep, straightforward. It's a diabetic ketoacidosis. The idea is, how do we recognize diabetic ketoacidosis? Can someone say, is it 1, 2, 3, or 4? Just shout. 1. Great, that's it. Right. So you need the 3 to say this is diabetic ketoacidosis. And remember, it's D, K, and A. It's easy to remember. D is the presence of diabetes or blood sugar more than 11 millimole, which is 200 milligram. So you need the D. And previously we used to have 250 cutoff, and this is we added recently because even if somebody doesn't know to have diabetes, it doesn't need, you could have diabetes even if you have type 1 or type 2. In the old guidelines, we say only type 1. Potassium, the K is for ketones. So you need the urine ketones more than 2+, or you have capillary ketones, which we use most of the time. And the A stands for acidosis, which is either the pH less than 7.3 or the bicarb less than 15. So you need D, K, and A to diagnose the DKA. Now this has changed recently because we merged with the Americans and now we lowered the hyperglycemic cutoff to more than 200, 11.1, and we added the prior history of diabetes irrespective of the glucose level, and that's basically because of the euglycemic DKA, because 10% DKA occur with normal sugar or near normal sugar. But we have other types of DKA, as we say, we have alcoholic diabetic ketoacidosis. Here, the blood glucose could be normal or no normal, history of alcohol excess, starvation, and they're not on SGLT2. It could be very tricky to differentiate, is it alcohol DKA or diabetic ketoacidosis? Sometimes you have to go and find if there is previous A1C, look at the history, and look at the patient in front of you. And as you know, the euglycemic DKA because of the SGLT2 inhibitor when the blood sugar is normal. So what could trigger diabetic ketoacidosis? Could be new presentation of type 1 diabetes, could be infection, MI, CVA, trauma, sometimes mismanagement of insulin most of the time, and mostly insulin pump malfunction, tubing problem. Type 2 diabetes could have diabetic ketoacidosis because of either medication or because the sugar is very high. Having DKA doesn't mean always type 1 diabetes. It could be with type 2 diabetes. The severity is important, so we should always categorize it as severe or not, because that's important to decide where the patient is going. If you find a severe DKA, I wouldn't take them to the ward. I call intensive care or high dependency unit to take the patient. So you look at the ketones, how high is the ketone, what's the degree of acidosis, what's the mental state of the patient, and this suggests the level of care is different. It doesn't matter where you treat, because we had a big debate in the UK where to treat those patients. 16 years old, is it adult, is it pediatric? It's whatever you're comfortable with. If you treat them as a kid, go to the pediatric. If you find them that big enough to be treated as adult, take them, but don't delay the treatment. And so when you get a phone call about a patient asking you to accept and take to the ward for diabetic ketoacidosis, if you find any of these, just pick the phone, speak to the intensive care, run it by them, make sure they know. These are the signs of need urgent review by high dependency unit. If they're young, if they're elderly, pregnant, if there is heart or kidney failure or other serious comorbidities. If the pH less than 7.1, don't accept straight away. Call the intensive care. If the potassium is low to start with, because it will be lower anyway. If there is a change in the GCS or the saturation or the blood pressure. So don't accept anybody. Ensure they don't have signs of severe diabetic ketoacidosis. If yes, run it by the intensive care people first, because they may need a high dependency unit. Right. So what do you think in 60 kilogram man with DKA? What's the average fluid deficit? How much we should give? It's 6 liter. Yes. So it's C. So this is where we use the JBTS guidelines. First hour, you give 1 liter over 1 hour, and then 1 liter over 2 hour, 2 hour, 4 hour, 4 hours. First hour, you don't give potassium because it will be slightly raised. From the next few hours, you give the potassium. When the blood sugar reaches around 14 millimole, you have to add dextrose to prevent hypoglycemia. And recently we changed that in 2021. You could either reduce the rate of insulin or you can add the dextrose. Now, the key thing to consider, that doesn't fit everybody. For a 20 years old male who present, that could be fine. For an 80 years old lady with heart failure or CKD or on dialysis, you can't give the same amount of fluid. The key thing is to monitor the ketones and give insulin. The fluid you can adjust, maybe you can make it slower just to prevent pulmonary edema from happening. So this is not a Bible, not set in stone. You can always change and give less. This is from the consensus, which was published in June 2024. Severe hypovolemia, normal saline 1 liter per hour. Mild hypovolemia, you can slow the fluid. If there is cardiac compromise, I would involve the intensive care or more senior people. We had an incidence of someone died because we give too much fluid, ended up in pulmonary edema. So be careful not to use that table in everybody. Elderly patient, comorbidities, you give the slower fluid and be very cautious. When it comes to insulin, we know we give fixed rate insulin infusion. It's 0.1 unit per kg per hour. And this is from the JBDS guidelines. And this is a rough estimation that depends on the weight, 50, 59, 5 units per hour. And then you monitor and you can adjust accordingly. And this is the most important steps in dealing with DKA. It's you should tackle the ketones. Ketones are more important. You tackle the ketones, it will improve things. Fluid, you can give it slower, that's fine. But tackle the ketones, that's the most important thing. And never stop the long-acting insulin. If the patient is already on degludec, Tresiba, make sure that's always carried on. Inject it and give the variable rate or a fixed rate insulin infusion. This is from the new guidelines, which is I was surprised to find that they say if the patient has mild DKA, you can just get subcut insulin, 0.1 unit per kg, and every 1 hour or every 2 hours. If you have somebody who has DKA, but he's well, eating and drinking, not having symptoms, you don't need to run and put them on IV drip. Give some subcut insulin because, as we said, we need to tackle the ketones. If the subcut insulin bring the ketones down, that's fine. You could prevent DKA from happening. If the subcut insulin is not helping, put them on a fixed rate insulin infusion. If you're not sure, just go with a fixed rate insulin infusion. In HHS, you give half the unit of insulin, but we'll come to that later. You don't need to start insulin straight away. So the key message is you could go with subcut insulin if the patient is well. If they're not responding, and to be on the safe side, just go with the IV insulin. Potassium is very important. As we said, we have always to replace potassium, not in the first bag, but from the second bag onward, depends on how high it is. You start with 40 millimole per bag. If it's below 3.5, you need senior review because with treatment, it will shift down. It will be, they may arrest. And make sure you monitor the patient. 0 minutes, hourly, you do blood ketones and glucose to make sure ketones are coming down. But you should do regular venous blood gas. You should do Usenis, and you should also make sure you do it 12-hour, 24-hour to ensure resolution. So monitoring is a key. And sometimes we miss that in a busy environment, acute medicine or emergency department, but make sure the junior is following this up. Complication, as we talked, death, it happened because it's increased mortality within 30 days. Cerebral edema from overcorrection and quick correction, hypokalemia, respiratory distress. I've seen, as I said, pulmonary edema because of that. PE because it's a hypercoagulable state, and sometimes hypoglycemia from over-treating. That's why when the sugar is less than 14, we add the dextrose. Right, so, if we give IV insulin infusion, what's the most abnormality in the electrolyte that we worry about? Just shout the number. 1, 2. Yes, we're afraid of hypokalemia because that could kill the patient. And basically because the insulin work on the ATPase, shift the potassium inside the cell, sodium out, and the patient would have hypokalemia. Initially, it will be hyperkalemic, and then insulin will start working and it will shift it down. Back to Tim, after 24 hours, he's brighter, his observation is fine, the pH is normal, bicarbs 22, ketones 0.2, it's fine, glucose is 14, but he's still vomiting, he's not keeping fluid down, he's probably had gastroenteritis from the excessive alcohol he took. So what will you do to him? Will you stop the insulin infusion? Or we continue? Continue, yeah, but he will have hypoglycemia then. Yeah. So first step, identifying DKA, fixed rate insulin infusion. Next step, patient is improve resolution. You put on a variable rate insulin infusion. So not fixed, but variable rate until he's able to eat and drink, as you know. As we said, this is a diagnosis of DKA, D, K, and A. On when will you say that resolution of DKA happened? It's when the pH is over 7.3 and when the ketones less than 0.6. You don't rely on the bicarb. We rely on the bicarb to diagnose DKA, but not to get out of the DKA because there is a condition when you have too much hyperchloremic acidosis because of the normal saline we give to the patient. So don't look at the bicarb, always look at the pH to say this patient is out of DKA. So in case of Tim, he's out because his pH and his ketones are fine. Even if the bicarb is low, that's fine, he's resolved. And when that resolved, we switch to variable rate until eating and drinking. Never stop the insulin because the patient is resolved. We back on some degree of insulin and always continue with the basal insulin. Now, how do you transit the patient to subcut insulin? This is from the JBDS front of diabetes guidelines, front of door, sorry. The couple of ways to calculate the estimated dose, either by weight, so 0.5 to 0.6 units per kg for total daily dose, and you put it 50% basal, 50% bolus, or you know what's the pre-admission insulin requirement and you try just to restart the same dose, or you go with the hourly intravenous requirement. So on a variable rate, he was on 6 units, for example, per hour. You calculate the 24-hour and you start the insulin. So there are 3 ways. They all have limitation. There is no guidance. This is just clinical practice. And you always give insulin, wait for the patient to eat and drink before you take the insulin infusion down. Don't just give it and take it down because they may have a rebound hyperglycemia. So this is DKA in a nutshell, how to treat, how to transit to subcut insulin. Moving on to another story. This is also a real story. I've seen this lady 3 years ago, I think. She was 89, came to the emergency department, unwell. GP treated her as chest infection and started some prednisolone because query COPD. She's very tired, increased urine frequency. And I looked at her blood test. You can tell that on the 14th of December, she has normal kidney function. Now her sodium is very low. Potassium is unrecordable. But look at the kidney function, urea from 8.9 to 29, creatinine from 64 to 90, EGFR dropped from 74 to 49. And also the calcium is high. So she is very extremely dehydrated. Also, the blood sugar is 52. 52 is like 900 milligram. So she's hyperglycemic. She's very dehydrated. And someone clever did the osmolarity and it was 355. So she fit the criteria for hyperosmolar, hyperglycemic state. But what the doctor did in the emergency department, he put no chest pain, no bifascicular block, urine nitrate positive, impression, hyperglycemia, variable rate, likely urine infection, start nitrofurantoin. So the lady, after 12 hours when I came to see her, she was in HHS, she's had just IV insulin infusion, no proper fluid, she was crispy dry. And we fed back to the emergency department that you missed an HHS here because you didn't know the criteria. So this is the criteria for the HHS. You need to have a hyperglycemia, glucose more than 600, 33 millimole. Also, the patient need to have evidence of hyperosmolarity. Either you calculate the effective osmolarity more than 300 or the total osmolarity more than 320. And in this patient, she was 355. And there is absent of significant ketonemia. So her ketones less than 3, not significantly high, more than 3. If it's more than 3, you treat as DKA. And there is no acidosis. So HHSS, this is the criteria. It's important to recognize this because the mole management might need to be changed. And some patient has both picture, mixed DKA, HHS. If you have that, you're not sure, you're not just treat as DKA. And in our hospital, we did this. We made it easy for the doctors. If you just put search on the order set DKA, tick the box, or HHS, tick the box, it will tell you exactly what to do. Still nobody following that, which is irritating sometimes. So this is exactly what you do. And in HHS, you do 1, 2, 3, 4, not being followed. That's why it's very important for education. Always remind the juniors, do that properly. If you're not sure, out of hours, just Google JBDS HHS guidelines. They will tell you exactly what to do. And this has been published recently, what to do exactly with HHS, because it's very vague. DKA, you have a very clear guidelines. HHS, sometimes you feel very vague, how much fluid to give, how to follow. This is very easy. You look at the osmolarity, you may increase the fluid. You start with the fluid. If fluid is not working, you may increase insulin later on, but don't start insulin straight away because it's hyperglycemia driven by dehydration. Sometimes only fluid could be enough. And you aim for a positive fluid balance, 3 to 6 liters by 12 hours. If the glucose is not improving, at this point you may add the insulin, or if the glucose is not coming down by 3 millimole by 5, sorry, per hour. Then you add the insulin. So don't rush and start with the fluid, and then you can add the insulin later. And the same principle as a DKA, how you give potassium with the fluid. And now they introduced criteria from exiting HHS, still not very agreed on, but first you have to get a clinical cognitive status back to the pre-morbid state. Osmolarity starting to go down less than 300. Hypovolemia is to be corrected when the patient is passing urine, and the blood sugar is less than 15. Okay. When you reach this criteria, you know HHS has resolved and you can step down the treatment. Okay. There are special population, not everybody is the same. As we said, frail older adults, fluid resuscitation need to be very, very cautious. You may give 1 liter over 8 hour, 8 hour, 12 hour, 12 hours. Don't look much to the fluid, but if the patient is DKA, focus on the insulin. In SGLT2 inhibitor, treat as DKA, as usual. Previously, we used to give half the strength of insulin dose, but nowadays it's as DKA. So don't delay treatment, just give it as a DKA. And you stop SGLT2 and you never restart it. Some patients still query type 1, you give SGLT2. Now we stopped giving SGLT2 at all. A few years ago, AstraZeneca was promoting DABA for certain patients, the body weight, insulin requirement. Now we stopped. Anybody who had DKA or positive antibody, we shouldn't give SGLT2. And end-stage kidney disease, the same thing. There are more risk of cardiovascular disease, and you should be very careful with the fluid replacement. In pregnancy as well, very careful with the fluid replacement, and mostly they have euglycemic DKA sometimes happens. Now, what if the patient doesn't have DKA, doesn't have HHS, just high blood sugar? Also, there is guidelines from the diabetes at the front door, from the JBDS, what to do, what the target. All you need to do is make sure you don't miss a DKA, so you venous gas, patient normal pH, normal ketones, then DKA excluded. Now you ask yourself, does the patient hypovolemic? Do they fit criteria for HHS? If yes, you manage as HHS. If not, you treat as non-ketotic, non-acidotic hyperglycemia. Now, if the patient is unwell, you put on IV fluid, IV insulin replacement. But if the patient is well, you can get away by giving stat doses of novorapid to bring the sugar down. And this is just a rough guidance. Sugar between 18 to 25, you give 4 units, and then you repeat after 4 hours if the sugar remains high. If more than 25, you give 6 units. Again, this is no Bible. This is just clinical experience. You can do whatever you're comfortable with. Back to Christine. What happened when the coroner asked the doctors to attend? This lady has DKA. It was treated, resolved, and she was moved to the ward. After 3 hours, her DKA recurred again. Sugar went up and the ketones went up. The junior doctor called the consultant on the phone and said, what should I do? I said, okay, now it's DKA, restart the DKA protocol. But at this point, she has a potassium of 2.5. So the junior doctor restarted the protocol with a potassium of 2.5. And after 2 hours, the patient arrested and died. After all the investigation, we found that there was 10 episodes that this could be prevented by picking up the potassium. Still, this hasn't happened. So we learned from this that very important to keep monitoring the VBG. If you find a low potassium, ensure you replace it and get the intensive care people before you start treatment. You can kill patients. This is from The Guardian. It's been on the papers. Everybody know about it now. The take-home message, hyperglycemic crises are common and can be prevented. Ensure you know what's the criteria, early recognition. Remember the DK8 HSS mnemonics. Be aware of the complications. Always monitor, and if not sure, don't try to be a hero here. Ask for help. Get somebody to help you. I finished ahead of time. I hope that's great. Thank you very much. Any questions? Everyone tired? Right. Thank you.
Somebody left their phone, but they will come back, I guess. Okay, first of all, very good of you to be here for the last session. It's going to be a fun session. It's about technology, which is always exciting because it's innovative and it's also my passion. First of all, thank you to the organizers for inviting me. Ah, the phone. Yes, good idea. I don't need my glasses. Ooh. Just explaining why technology is so important to, as you know, at this moment, or we know that insufficient glucose control leads to a lot of complication. Each 1% drop in HbA1c will lead to 21% less deaths related to diabetes, 40% less myocardial infarctions, and 37% less microvascular complications. These are data for type 2 diabetes, but just reiterating how important it is to get those A1Cs down and to get better glucose control. And nowadays, the ISPAT, this is for children with diabetes, is now recommended to go to an A1C even below 6.5% in children who have access to all this new technology. So with this technology, we can really aim lower and aim for better glucoses and less complications. The reality, however, is that at the moment, the average A1C of children is 9%. So it should be below 6.5, it's 9%. And in lower to lower middle income countries and low income countries, you see low income countries, it's the average A1C of children is 10%. This is something that should really motivate us to do better. And even in our countries, it's not on point yet. And that's where automated insulin delivery systems really come in. If you start, these are the Minimed 780G data. If you start this, no matter which country, no matter which clinic, the average A1C is below 7%. So the time in range is 74%, and these systems are getting better. As you can see, the data, they keep repeating the same thing. So it is possible, and you also can do it. The problem is there's a lot of technology, there's a lot of advancements. This can make us feel incompetent or give us not enough confidence to start using this, to start recommending this to our patients. That's why in this session, I will teach you how to use CGMs, so glucose monitors and AID systems, so you feel competent to start this in your clinics also. I'm an endocrinologist in Ghent in Belgium, and my passion is diabetes technology. I've created a non-profit, Diabetotech, and we create online video courses on glucose sensors and insulin pumps. And if you stay until the end, you can scan the QR code and you will get access to all our courses. Just to move it along. So the first point is CGMs. I will go over the different CGMs, the indications, the reliability, interpreting report, practical tips, and I will do kind of the same points for the AID systems. It's going to be a lot of slides, but at the end you get a QR code, you can get the slides, and it will be easier to go back to. So if you don't capture everything, try to get the most points. And look at the visuals. Yeah. So the most used CGMs, you know, this one is the Freestyle Libre. So it's a sensor and transmitter in one device. The sensor life is 14 days. You still have to scan it with the app, and you have to scan it every 8 hours or you lose data. So this is something you should recommend to your patient, at least scan every 8 hours. And unfortunately for this sensor, there is no alert function. But I heard the Freestyle Libre 2 is also being introduced in India, which will have an alert. And in Europe, actually, the LibreLink 2 app, no longer people have to scan. So I hope that update is also coming soon to India. So what are the next sensors? Is the Freestyle Libre 3, the Dexcom G6. Do I have a pointer? Yeah, so the Dexcom G6, you know, which is still a transmitter and a sensor in a different device. But the G7 or the One Plus, it's all in one device. Guardian for Medtronic, it's the same. So the sensor and the transmitter in different devices. But the updates, the Simplera, it's all in one device, putting it on the body with one click. So it's getting easier. Here is an overview of the most used glucose sensors. So we have the Freestyle Libre 2 and the 2 Plus, the Freestyle Libre 3 and 3 Plus. I think this will, the normal versions will go away and they will all become the Plus versions. The Dexcom G7, so that only has a 10-day wear time. G6, G7 has 10.5 days, OnePlus has 10.5 days. The Medtronic sensors only are for 1 week that they can last. So every week you will need to change. And for the Guardian 4, the transmitter lasts for 1 year, but in reality it lasts for 1.5 years. Be mindful of the age limits, but so it's only the Guardian Medtronic sensor, Guardian 4, that it's only approved above 7 years, but we know a lot of diabetes clinics are using these also in people, children who are younger, and there is scientific data that it is safe and it works. There are, of course, a lot more sensors. I think Cybionics is available here in India, and ICANN from Sinocare. But there are a lot more Asian versions, and also the Rush sensor is going to be introduced soon, or is already introduced in Germany. And then on top of the normal sensors, there is also a lot of development in non-invasive CGMs, you know, the smartwatches and the other devices. And there's actually a free ebook on our website with all the specifics. If you ever get questions from patients, so what about this device? What about this device? That you can check how that goes. The ebook is available on the website, so diabe.tech.com, everything is available there. So the indication of sensors, so for people on intensive insulin, it's very clear. If you give them a sensor, the HbA1c will drop. You will have less hypoglycemia, and people will be more content. They will be less burdened with their diabetes. But also there's a lot of evidence for people on basal-only insulin. Here you see a big study in 175 patients who were randomized for a sensor. So 116 got the sensor and 59 got the finger pricks. They were all on basal insulin. And you see that with a sensor, the HbA1c drops 0.4% more. So it's just an effective therapy. It's not a lot, but it's better than the finger pricks. And also for people with diabetes not on insulin, they see if you compare that to SMBG, the HbA1c drops around 0.3% more. But that really depends a lot on the study design and on the study population. I guess some studies show better results and some show a less result. So the recent guidelines, already before they were recommending sensors for people on intensive insulin therapy and for adults on basal insulin therapy. Now it's for everybody who uses insulin. We know they will do better on sensors. And for the first time, they also recognize that people with type 2 diabetes, even not using insulin, they might do better with sensors to get to their personal glucose goals. And also for gestational diabetes or for diabetes in pregnancy, it's acknowledged that sensors might help. So here is the overview. It's diabetes on insulin. I guess everybody agrees that there's really enough evidence that this will work. And here you see guidelines that were published in Nature that they recommend that everybody who gets a diagnosis of diabetes it would be good that they get a sensor. And everybody on insulin, they have good evidence of continuous sensor use. And maybe if you don't use insulin, it will be better to use intermittent sensor use, as it will be too expensive, because we expect a cost-benefit analysis for continuous glucose monitoring and people without insulin not to be efficient. What about reimbursement? There in New Zealand, Australia, it's reimbursed for people with type 1 diabetes. In Europe, it's reimbursed for people everybody on intensive insulin, so also people with type 2 diabetes on intensive insulin. There are more and more countries who are also reimbursing this for people on basal-only insulin. In America, the biggest group, so Medicare and Medicaid, it's reimbursed for people on insulin and also on sulfonylurea. And here in Missouri, in UK, in USA, also for gestational diabetes. And I heard in USA there were also some people who get it without insulin and without sulfonylurea. So the biggest we are moving to using more sensors for people not on insulin, as it does not only prevent hypoglycemia if you use insulin, but it also can be used as a biofeedback mechanism, as CGM therapy, as an educational tool. And then the next question, of course, and this is the most ambivalent question, will it be effective for people with prediabetes and obesity? And I think most people tend to say yes, but there are still a lot of doubts there. There is no proof yet that it will be especially cost efficient. So if you give people with prediabetes a sensor, this will have a good effect on their diet, but especially if you give them good education. Because of course, if they start eating salami and a lot of meat to get less glucose spikes, this will not be beneficial for their health. So ideally, people who get a sensor, if they're prediabetes or they use this for better, for obesity, you should tell them about which food is healthy, because not all food that doesn't give spikes is healthy. There are a lot of companies who are already offering CGM to people without diabetes to get better metabolic profile. And then there are also these companies that are taking it just a step further. They say you're going to have better sports performance, you're going to lose weight, you're going to get more energy, and then take our supplements so you can still eat the cake. Of course, that is taking it a step too far at the moment, but maybe in a few years we might say, yes, this is true, or in what degree it is true. At this point, it's a little bit too soon to say that. And in the meantime, Abbott and Dexcom, of course, are promoting their sensors and making them available even to people without diabetes. And they're doing massive studies to try to give evidence that this actually works. So for people without diabetes, CGM can motivate healthy behavior. I think we all maybe wore a sensor once and you see directly the influence. So it can motivate you to try to reduce healthy spikes with healthy behavior. And it also can detect pre-diabetes or diabetes faster, which would be very good, as a lot of people don't know they have diabetes. On the other side, there is no proven effect that you will live longer or you will be more healthier or you will lose weight if you reduce the spikes. It all depends on the link with your behavior. It can cause a lot of stress and anxiety, so you have to warn people that if you don't have diabetes and you're going to wear a CGM, you're going to have spikes, you're going to have hypoglycemia, you're going to have compression lows, that they don't get that unnecessary anxiety. It's best to give them education. It can give some skin reactions, which you can warn people about. Then the reliability of CGMs. Important thing in an education, especially for people who are using insulin and who are really changing their treatment based on their CGM values. It's explaining that a sensor value is different than a blood glucose value, because a sensor value measures in the interstitial fluid, and the blood glucose, in the blood glucose you see the spikes and the drops sooner than in the interstitial fluid. So there is a lag time, and it's important to notice that if you have, for example, if you have hypoglycemia and you take food, that the effect on the glucose sensor will be delayed. So if you see that your glucose is still low after food, you should wait. And if you want to be sure, you do a finger prick, then you don't have that delay. And the same if you give a correction bolus of insulin and your glucose stays high. This is a problem if you give people sensors without education. They just are going to rage bolus and keep bolusing because they don't see the effect. But they should learn that they should wait and there is a delay. Then you have, so they should get education about trend arrows. Here you see that in general, if there's a spike going up, your glucose might already be 30 milligram per deciliter higher. And if there is a trend going down, the glucose might already be 30 milligram per deciliter lower. And this is also the kind of education you can give to your patients. If they're experiencing maybe feeling low and the glucose on their sensor is 90, but the trend arrow is down, they're probably going to have a hypo. They're already having a hypo. And the same if the glucose is 70 and the trend is up, they no longer have to eat. Then the reliability, that's not an easy topic. In general, you can say that the sensors that are approved, they are accurate enough to dose insulin on. However, if you do finger pricks, that will always be more reliable. So if you're doubting, you should do a finger prick. So the sensors today, they have a MARD, or a mean absolute relative difference, of below 10%, and that's being said to be accurate enough. But there is also a lot of publications, discussion around the MARD not telling the whole story. So MARD is mostly being used as a commercial tool from the firms to say it's good enough, but it actually depends a lot of the studies they are doing. So please tell your patients, if they're not feeling how the sensor is measuring, they need to do a finger prick. They cannot trust their sensor blindly, especially if they're on insulin, because then they can really take the wrong decisions. And then, of course, you have the people coming back to say, yeah, but my sensor is not working. The difference is too big. So if you're going to start using finger pricks to see if your sensor is accurate enough, you should explain to your patients that the first day the sensor will not be as accurate because it has to come into the body. And so on the first day, you cannot make assumptions about the accurateness of the sensor. And then you can also only compare sensor and finger prick if the glucose is in range, so between 70 and 180, and if it's stable. Because remember, if there is an arrow up or down, the finger prick will be different, and they should always wash their hands. And then interfering substances, there are actually not a lot. So for the Freestyle Libre, it's only the vitamin C. I'm not sure if people in India take a lot of vitamin C, but in Belgium, they actually don't. And then acetaminophen, that's important for Dexcom and Medtronic. So just say if they are ill and they don't feel how their sensor is telling them, they always have to finger prick. But for people who take paracetamol, they might be more vigilant. That's what we tell patients. So it can give false high values. CGM can be used during hospitalization, but the accurateness is lower. So if on average and accurate, the MARD of a sensor outside of the hospital is 8-9%, in the hospital it's 13-14%. So it's still accurate enough to use, but you need confirmatory finger pricks because people who are ill, somehow their sensor is less accurate. Be aware that they will have to remove their sensor if they go under an MRI, but for the RX and for the scanner, they can leave it on. Some people say to do a lead apron. There's not much publications about that. In general, we leave them on, but maybe it's best to do a confirmation afterwards. Freestyle Libre 2 and 3 sensors can only be worn under MRI, but you do have to check them afterwards, and it's only in special conditions. And also during surgery, the CGM can stay on if the anesthesiologist agrees and according to a protocol. Now the reports. So each CGM firm has their own data platform. Abbott has LibreView, Dexcom has Clarity, and Medtronic has CareLink. But in general, they give the same types of reports. They give an AGP profile mostly, or a summary report, where you can find the GMI, the time in range, and the time below range, which are the most important parameters you need. Then you will find the daily reports, and there will always be a device report. Now, different companies give additional reports, and you can look at those. But if you'd like to have the same structure, you will find these reports always with the big companies. I will go over the LibreView, as I guess the Freestyle is the most used sensor. So if you have people with Freestyle Libre sensors in your clinic, this is how your LibreView Pro account will look. You can make this for free online. You can connect people to this platform in a matter of seconds through their app. So you click on the patient, and then you see, first you have to check if the data is there. So you can see on the first page already, when was the last data upload? And if you see that's the one you need, then you can click on the glucose reports. If not, go to the patient's app and renew the connection with your clinic. So here you see for LibreView, there are 9 reports, and the top one is the AGP report. Below, you can check the report settings. So for people who don't use insulin or who don't have diabetes, it's better to put it on time in tight range, so 70 between 140, because everybody otherwise will have a time in range of 99%. And also for people who are pregnant, it should go to 63 to 140. Here you see the time in range targets. So the AGP profile, you can use it for shared decision making. And the first thing you have to tell your patients is what are their goals, and then you look at their results. So most people have a time in range goal of more than 70%. So people with type 1 and type 2 diabetes, and a time below range, which is also important, should be below 4%. So those are the two most important numbers to tell to your patients. But there are also people who are older and who have a high risk of hypoglycemia. And then you say the time in range target is more than 50%, that is enough. And the most emphasis is on not having a hypoglycemia. So the time below range should be below 1%. For pregnancy, we are stricter. As you know, in pregnancy, the glucose values are lower, so it should be below 63 and 140%. For people with type 1 diabetes, we are happy with a time in range for pregnancy of more than 70%. And then for people with type 2 diabetes or gestational diabetes who are pregnant, there is no consensus on the value of the time in range in pregnancy, but in general we try to get that above 90%. And then for pre-diabetes, there is no consensus yet, but there is a paper who suggests that the time in tight range, or the time in range between 54 and 140, should be above 95%. So if you have people not on insulin, we are trying to get them even better. So the AGP report, how can you do the shared decision making together with your patient? There is an easy way to do this, and that is in 3 steps. Determine where to act. And this is also how the AGP report is created. So determine is the top panel. So determine the personal goals and determine what the time in range is. And you aim for more green and less red. So more time in range, less time below range, but think of the personal goals also of that patient. The second step, so the first step, if everything is okay, you can say very well, you did very good, and you try to motivate your patients to keep doing a good job and take their medication. If they're not in goal, you go to the second panel and you see where is the problem. So the AGP profile here, that picture, shows the glucose values between 0 hours at night to 0 hours at night of the last 14 days, or however you set the report. And the curve should be flat, narrow, and in range. It's also easy to remember, but it's very logical. You should have it like as normal as possible and between the targets. They also say that it's best to treat hypoglycemia first. So first focus on hypoglycemia, and then if there is also a problem of hyperglycemia, you can discuss that next. Of course, you can do it whatever way you want or how the conversation goes, but it's always easy to have this kind of structure in mind, also to give your patient like a hold on to check their AGP profile themselves. And then act on the data that you do together with the patient. So before changing anything, go to the daily views and ask your patient what happened there. Is it not a special day before you start giving advice? So you can also go to the daily reports here and together with your patients discuss where were the spikes, what was the cause of it. Here is another view, the snapshot of the Libre view, where you can see very well the hypoglycemia. And then maybe some information on how to use sensors for people who, for nutritional advice. I heard some good guidance from Dr. Bergenstahl, who said it's to do this in a non-judgmental way. So the easiest way is to look at this picture together with your patients and then ask them what they think. What did you learn when you wore those sensors? What have you eaten? What do you think would make this better? So this is less judgmental than saying, look what you did here. Yeah, I think you ate something wrong. And then make some suggestions, like would you like to try an unsweetened drink in the morning? Would you like to see what the effect would be on your sugar of another snack? So this can be helpful to make the conversation more patient-centered. I'm just gonna go show you a case of a person who is not using insulin, but she is on maximum oral anti-diabetic drugs. And this is the way how I use mostly sensors in people who don't have them reimbursed, but might help. And this is like the moment they need insulin, because then they're very motivated to do something on their health and to change their behavior. So here, this was the moment for this woman to start insulin because her HbA1c was too high. And I suggested to wear a CGM. And this person, the longer she wore the CGM, you see the HbA1c really drop. So I saw her back after 3 months. And she said, yes, because I saw the values, I started walking every day, I started to eat fewer carbs. She had been to a dietitian to help her to make healthy choices. And this is a person who really got the benefit of like postponing insulin thanks to the CGM. Then the practical tips, I will go very quickly, but you can have the slides afterwards because I also like to give some time on the insulin pumps, which is really the most fun. So you can let people buy the sensors online. There's a lot of education online, which you should recommend people to follow or give the education yourself from your team. As you know, there is a sensor box and the applicator. There is the app they need to download. They need to scan the sensor. People might have problems with the scanning, so say they have to be patient, and the Android phones, the NFC is on the back, on the iPhones, it's on the front, so there is a little bit difference there. There is a lot of people, 1 in 3 people, they have eczema, they have itching, but in general, nobody stops with the sensor. But these skin problems should be acknowledged. Most complaints are a few months after starting the sensor, so that's a problem. The most important thing is that we exclude contact allergy. I do not see a lot of contact allergy anymore. I think it's more with maybe with the Freestyle Libre sensors, there's still contact allergy. But if it's really dead red and there's blistering, there's liquid, and the redness is outside of the sensor, that's no longer normal. This is not like just keep trying the sensor. Here you should stop the sensor and do another brand. I think with the newer brands, we don't have that problem anymore. But it is possible that there is really an allergic reaction. Mostly it's about contact irritation, and then just educate the patient on protecting their skin. So how can you prevent this contact irritation? Use unscented skin products to have like a good skin barrier. Also after the sensor, you can advise them to do a lipid-rich cream to heal the skin. Be very careful when you remove the sensor, not too fast, but low and slow. You can use additional products to make sure that the sensor comes off without damaging the skin. There are products you can use. Don't do it after a bath of a shower because then the adhesive is stronger from the heat and the humidity. Then if there is allergy, if there is contact irritation, just let them stop using the alcohol wipes, but let them use other wipes or maybe no wipes. And be sure that the wipes or the product always dries very well before they apply the sensor. Be sure there is no hair. If people sweat a lot, they can use deodorant before they apply the sensor, and it should always be on a good place. Like the same way, if you place an insulin pump, it should not be on places that fold or that is already irritated. And you always have to change sensor sites because you have to let your skin heal. Then there is some barrier plasters that you can use, different ones. I guess in India, there are also different brands. You can let people cut out the sensor placement and then cut out a place for the sensor wire. In Belgium, we don't use this because we have less of this allergy. I think if you have a good preventative skincare, you can manage. There are also, you can buy under patches. And what I do prescribe a lot is the cortisone cream and sometimes a cortisone spray to do before they place a sensor, that they do cortisone spray, but it should dry. I don't think they use it a lot, but the cream, I advise to use it if it's red. If people are complaining that the sensor comes loose, you can advise them to do additional tapes. There are all sorts of tapes. There is basic skin prep taping techniques. There are glues that you can put on, extra glues. There are little bands around the sensor possible. But I really want to talk about like the most fun thing about diabetes these days is this artificial pancreas that is available. So I'm going to talk about the indications of automated insulin delivery systems, different insulin pumps, insulin settings to start an insulin pump, and the different AID systems in the last 15 minutes. So you're all up to speed. So an AID system, it's three components. It's the sensor, it's the pump, and it's the algorithm. So if the glucose goes up, the pump every 5 minutes will calculate it will give more insulin. If the glucose goes down, it will give less insulin. At the moment, users still need to announce their carbs, and they still need to say if they're going to do exercise. But these systems, they work so well. So the time in range, if you start these systems, you can expect it to go 10% higher. People will have less hypoglycemia. They will still have hypoglycemia, but it's less. It's around 2%. They have less fluctuations. They have less diabetes burden, and they will sleep better. And I say to my patients, so imagine that if you sleep and on the morning, your AID system brings you always to 100, like that you can start your day with a good glucose, and that's how we can really convince our patients. Although there are still a lot of patients who don't want anything on their body, especially not with the wires. But yeah, it will become easier in the future. There is enough data that people who have high HbA1cs or who are not that compliant, I know I cannot say compliant, but they actually have the biggest results. They have the most effect of these AID systems. So these systems are good for anybody with type 1 diabetes, children, old people, and even in people who don't bolus. If you put like an algorithm in between, the insulin delivery will always be better. So the guidelines, ADA guidelines, they say AID systems are recommended for everybody with type 1 diabetes, also for people with insulin deficient diabetes and people with type 2 diabetes. There is also evidence if they're on insulin, but of course we are all aware that there is not available and cost issues to be solved. We should also support people who use open source AID systems. And for people who are pregnant, it's also important, especially if they have type 1, to use AID systems for a better outcome of the baby. So here is the conclusion of the guidelines. So pumps, for people who, I guess everybody knows this, so there are two kinds, tubed pumps and patch pumps. And for the tube pumps, there's also two kinds. You have the tube pumps with a long catheter, which you can wear in your clothes, like the Minimed 780G. But there are also pumps with a very short catheter that you wear on your body. So for example, Tandem Mobi or Kaleido pump, you can wear them on your body or in your clothes. So that's semi-patch pump. And then you have the patch pump. We all know the Omnipod pump, which is a disposable patch pump, but there are also a lot of modular patch pumps who might hopefully be cheaper in the future, because they can keep reusing certain parts. And so you have a fixed pump base and then a replaceable reservoir. They all have to change every 3 days, except some, like Minimed, has this extended wear infusion set, which can last for 7 days. So here you see some pictures of tubed and patch pumps. And there is also in the ebook an overview of all types of pumps, where you can see also all the specifics of the pumps. There's a lot of pumps available in different parts of the world. And there's a lot of pumps that are still in development also. In general, you can see that the pumps in development, it's all patch pumps. And they're also all working on pumps that stay longer or can maybe hold more insulin than the 200 units. Here is how you can wear for example, the Minimed 780G on your body. There's a lot of clothes that are being designed to have an easier wear if people are complaining of that. And then you can disconnect the pump when you shower, for example, but maximum 2 hours. This is something you should tell to your patients, because the moment you disconnect your pump, people are starting to get ketones. So it cannot be longer than 2 hours. I want to teach you how to start people on an insulin pump, so you have full confidence on starting AID systems, because this is the first step that we need to do as healthcare providers, calculating the starting doses. So in general, it's going to be people who are on basal bolus insulin that we are getting to the pump, which only holds short-acting insulin. Sorry. So as a physician, you need to tell your team which basal insulin rate they can start, which carb ratio, with insulin sensitivity, glucose target, and duration of insulin action. These are the 5 parameters you as a healthcare provider have to give to your team to start a pump. So let's calculate the basal insulin rate. Of course, you can say you just take the dose of long-acting insulin and put that in the pump, but there are some other rules that you can use to make it easier. In general, it's advised to make the sum of all the insulin that your patient gets. So you get a total daily insulin dose. And if you transfer to a pump, you take 80% of it, because somehow the insulin from the pump works better. If you put people on a pump, you're going to see that they might do a lot of hypoglycemia. So just take 80% of that total insulin dose as the start total insulin dose for the pump. Some people say 70, some people say 90, like there is, yeah, you can take it, take 80. And then half of that insulin dose goes to the basal insulin and half to the bolus insulin. Also there, some people say it should be 60-40 or 70-30, and it depends a bit on how much carbs your patient is eating. But to keep it simple, just take 50%. And then the basal insulin rate is then that basal insulin dose divided by 24, because a basal insulin rate is an hourly rate. So here is an example. If you have a patient that takes 30 units of Lantus and 3 times 10 units of short-acting insulin, oh, this has to be solved together. How much total daily insulin would that be? 60, correct. So 80% of that, how much would that be? 48. And so the basal insulin dose, 24. So the basal insulin rate, 1. So this, yeah, I took an easy example, but just saying it's easy. And to be honest, I ask my team to make the calculations and I just have to approve. So you can choose one basal rate, or you can make it a little bit more complicated and choose a circadian basal rate. And this is mostly being used for manual pumps. But of course, if you know you're going to start a Minimed 780G, it's not going to be that important to have circadian basal rates. So the circadian basal rate, you take a little bit lower insulin rate at night, a little bit higher maybe for the dawn phenomenon. But yeah, nowadays, personally, we no longer use it because everybody's on AID systems. But it can be used. And then ideally, you check if your basal rate is correct. So this is mostly important for people on manual pumps, because again, if you're on an AID, it's not going to be that important, and there's not going to be a lot of parameters you can change. But if you're maybe on a pump where the basal rate is very important, for example, tandem pump or a looper, then you have to make sure the basal rate is correct. So for the basal rate at night, you look if there is a drop or a rise at night of the glucose, and then you change the basal rate according to the hours. Here, it should be a little bit less at night, for example. And during the daytime, you can check your basal rate. If you have a period of 5 hours where the person is not eating and you see if the glucose repeatedly drops or rises, then you can say, maybe my basal rate there is a little bit too high or too low. And then the bolus calculator. These are the 4 settings of the bolus calculator that we should all really know. A step back is in a pump. You can give insulin as a manual bolus or with a preset bolus calculator. And there are also different types of boluses you can give. Again, this is less important if you're on AID systems. So the first parameter of the bolus calculator is the carb ratio, and that's actually the number of grams of carbs that can be accommodated by 1 unit of insulin. So the number of grams that you only need 1 unit of insulin of. And in general, it's between 5 and 20 grams per unit. So a question, if you have a meal with 50 grams of carbs and the carb ratio is 5, how many units of insulin will be given by the pump? 10. Is it correct? Yes. So if you have a carb ratio of 5 for 50 grams, it will give 10 units. Carb ratio can be calculated by the 450 rule. Some people say 350, some people say 500, but 450 is like the average. So you take 450 and you divide it by the total daily insulin dose. So if you have a total daily insulin dose of 60, how much would your carb ratio be? 7.5, I needed a calculator for that, but you like knew it out of your head, which is great. So that's how you can easily calculate it. We also let people go to a dietitian just to check if that 7.5 grams per unit is also real, what the patient is really doing. So the dietitian will check how many carbs this person is generally eating and how many units this person generally gives for this type of meal. And then she will say the actual carb ratio of this patient is that. And then we compare both numbers to decide which we're going to put into the pump. The carb ratio can be checked on the reports. For example, here on Minimet reports, the glucose value after a meal, 2-3 hours after a meal, should go back to the glucose value before the meal. If it's higher or lower, your carb ratio is not correct and can be adapted. Insulin sensitivity is also a very important parameter in an insulin pump, and it's actually the number of milligram per deciliter of glucose that can be accommodated by 1 unit of insulin. It's generally around 30 to 50 milligram per deciliter per unit. So here is an example. If the glucose is 250 milligram per deciliter and the insulin sensitivity is 50, you will need 3 units of, the pump will give you 3 units of insulin to go back to a glucose target of 100. And here you can see, for example, the glucose is 250. If you go to the bolus wizard, the pump will suggest 3 units of insulin, and then people can choose to deliver this if they want to do a correction bolus in between. And that's how the pump uses this insulin sensitivity. You can calculate it very easily. You can choose the 1,800 rule. Some people use 2,000 rule. Some people use 1,600 rule. But yeah, 1,800 is in between. So for a total daily dose of 60 units, you can start with an insulin sensitivity of 30 milligram per deciliter per unit. The other bolus calculator settings, they speak for themselves. They're very easy. The target glucose, mostly people choose 100 or 110. And the duration of insulin action is in general between 3 and 5 hours. But if you use the Minimet, you better take the 2 hours because it's like a different setting there. So this is how you calculate the settings to start an insulin pump. And I hope you feel a little bit more confident. I know it went really fast, but you have some idea of how it works. And I just want to reiterate how easy it actually is. If you do this 2 times, or actually you can ask your team to do this. Very important is educate your people on the risk of ketoacidosis. If people on a pump, their glucose stays high for more than 2 hours, they should think of an infusion set problem. They should change their infusion sets. They should not wait. Even if they are on AID systems, they should be educated on ketoacidosis. This is the biggest risk if you put people on a pump. If in doubt, change it out. That mantra can help patients. I have a few minutes for the most commonly used AID systems. The most important one is the Minimet 780G here in India. It's approved from 7 years old, but as I said, there's a lot of data also in children, and we expect the indication to be from 2 years very soon. Unfortunately, you can only use it from 8 units per day. It's the most widely used systems. It has very good results, and it also has a 7-day infusion set, but I'm not sure if it's available in India, that set. The problem is it's a very large pump. Tandem Control IQ, it's a little bit smaller and it looks nicer, the pump. It can be connected to 2 types of sensors, the Dexcom sensors and also actually the Freestyle Libre 2 in some countries. It has more adjustable settings. Here it's a different algorithm. They really modulate the basal insulin you set. This here, the basal insulin settings are very important. Here are the updates that are planned for the Tandem pump. So you see the Tandem Mobi pump that is already available in the United States. My Life Loop system is also available in a lot of countries where the algorithm is on an Android phone. It works with the Ypsomed pump and with the Dexcom G6 and Freestyle Libre 3 sensor. Here the algorithm is on the phone, so you have to keep the phone nearby or you go to manual mode. But this system is actually approved in pregnancy and for children from 1 year old. Omnipod 5, the system we are all waiting for, where the algorithm is actually on the pod. So even if you don't have your controller or your phone with you, people stay in automated insulin delivery. Problem is maybe the lowest target is 110, so the results are a little bit less than the Minimet 780G. Beta Bionics is very interesting because as healthcare providers, we only have to set the weight and people no longer have to count carbs. So this is really AI enabled. And InReda is not yet on the market, but here you see an example of a pump with insulin and glucagon, where people no longer have to announce any meals or exercise. So we are seeing advancements. And then, of course, the loopers who are building their own apps. These apps are free. They can connect pumps and sensors that are cheaper, and that these open source AID systems are as safe and effective as commercial AID systems, and they make the technology more available to tech-savvy people. Of course, it's at their own risk. So here are the systems that are available in India. That's the Minimet 780G and the loopers. And for the future, there's a lot of advancements coming. It will be difficult to keep up. These are the open source AID systems. I want to go to my conclusions. So sensors are recommended for all people with diabetes on insulin. They can be considered for adults with type 2 diabetes not on insulin. And they are also being used for people without diabetes to improve lifestyle behaviors. And I guess we will see that without all these complications and hopefully living as long as people without diabetes. To help you with this enormous job and really fun job, we created the Diabetes Technology Expert Program. And this has more than 30 modules that discusses all the sensors and pumps, and it's all accredited for Europe. But it's an easy way to give scalable education to your team. So everybody of your team is confident and you can really delegate all the education to your team members. So feel free to scan the QR code to get this presentation, but you already have it in your platform. But this QR code also gives access to 3 months of free use of the courses. So good luck and have fun. I'm not sure if we're going to take questions or if we can close it and then the questions are the next day probably. Yeah, I think it's late enough. Thank you so much. See you tomorrow.